Yeah. Can you
Yeah, good
see my
evening.
slides, Tanuj?
Yes, yes, we
Good
can. We
evening.
can. Good evening, Dr. Kundu.
Reena madam?
Yes,
Reena madam is here?
yes, yes, I'm here. I'm very much
Okay.
here. So, Dr.
Yeah,
Kundu,
yeah.
you're going to be going first
Thank you.
on your experience
Yeah.
with new
Th-
generation presbyopic correcting IOLs. So, over to
Yeah.
you.
Okay. Thank you, madam. So, oh, first of all, I've been part of this Pan Ophthalmologica conference from last 3 years. Thanks to Reena madam and Arun Shetty sir for giving this opportunity. It did the one of the great job both sir and madam been doing uh, in as a Indian ophthalmology, and always proud to be. We are always proud to be like a part of like All India Ophthalmological Society. So I'm going to talk about my experience with the new generation presbyopic correcting IOL. Not moving slide. Yeah, this is my financial disclosure. I'm consultant to Carl Zeiss India. So just a minute. It's not going up. Slide. So as you all know that normally the crystalline lens has got a good accommodation, clear vision at all distance, clear vision in all lighting condition with a greater sensitivity. But can an intraocular lens not moving the slide? Yo, not moving slide.
Can the
What
IT team help him, please?
What happens?
somehow slide is not moving only. Yes. Now,
Okay.
can you see? Yeah.
Yes, yes,
Can
we
an
can.
intraocular lens can do the same job as the natural lens? This is the question to all my friends. I think no. So coming to the visual assessment,
You muted yourself, Dr. Kundu.
Sir, you have muted yourself. Please unmute.
yeah, I'm sorry. I just wanted the whole system audio, video, participant chat, share. It's coming exactly in the center of the screen. How to make it disappear?
Kudlu, you have to go on the view on the
Tarun,
up on the right
Tarun,
side. That's the
hello. Can
view.
you hear me? Yeah, 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 yeah. Now, perfect. So, can you hear me?
Yes.
Can you
Yes, we
hear
can.
me?
Yeah, yeah, we can hear you.
We can hear you very clearly.
Yeah. So, yeah, yeah. Coming to the visual potentials of the eye, always, whenever patient comes to you, it's very important that you have to slides again not moving. Amma. Sure. A slide in between started moving again not moving. Yeah. So coming to the clinical judgment, normally history taking is very important. History of amblyopia, we need to look at the pinhole vision, we need to look at the color vision. Very important, all comorbidity condition like age-related macular degeneration or glaucoma. Like, see, these are the few investigations you need to look at, especially. I don't have any financial disclosure, but all my patients, we do all this kind of investigation like eye trace, cam, OCT, very important. So precision, what always all my premium patient go, I do the dry eye workup. Look at the always I look at the cornea, especially cornea. I do the corneal topography. I do the OCT, rule out of any epiretinal membrane or age-related macular degeneration. But suppose like I have got a optical biometer, especially the IL Master 700, that even also knows whether there is a loose zonules are there, whether there is some amount of subluxation or not. And make sure that you should be always the patient doesn't have the glaucoma. So pre-op counseling is very, very important. I tell all my patients, especially, you need a extra light for reading. And also I show them the advantage of good range of spectacle free vision. And also should look for the other eye condition. So always I keep the option for monofocal whenever there is a technical difficulty during the surgery. So now I think the everyone needs is nowadays need to have a intermediate vision where this trifocal lens come in the play. So today I'm talking about this one of the new lens from Zeiss, that is the Zeiss 80 Elena 841. Basically it's a hydrophobic lens. We have been using their hydrophilic lenses. This is what 839. I have used these lenses around 3000 plus lenses, first user in India. I'm very happy with this lens. But now everybody is shifting to the hydrophobic platform. They need as less complication with the lenses. Complication means amount of glare and halos has to be as less as possible. So what Zeiss has done, they incorporated the old model of 839 into this newer model 841. Basically, now they have made something called a focal distance at 40 centimeter and for near and 80 centimeter for intermediate, so that patient will have a continuous range of vision. So the two, three very important factor I want to tell about these lenses. It's a pupil independent trifocal lens, and the technology they have made something called a smooth microphase technology, which is always good for the very good image quality and minimize light scattering. And also it comes with a spherical aberration neutral design. So if any lens comes with a spherical aberration neutral design, so the advantage is lenses have got a less sensitivity to decentration, also tilt during some of the any of the complication happen during the surgery. Of course, nowadays most of the lens comes with a 360-degree anti-PCO. But one important point I am looking at this lens about the very high Abbe number. Look at any lens whenever you are using any lens, always you should look at the very high Abbe number. If the lens has got a very high Abbe number, that means their positive photopsia is going to be as less as possible. Then of course all these lenses comes in the preloaded injecting system. So we have done the comparison with their regular trifocal with the 841. But what I have seen here, the light distribution is around 47.5 for distance. There it is 50%. Intermediate is here 17.5. There it is 20. Then near for 35 here, there 30. So the patient doesn't even near vision without high light also patient could able to read. As I said that because of this aspheric aberration neutral control, there is any problem during the surgery with some tilt or decentration, still it will take care about. This is about the point spread function. If you compare with the all other lenses, these lenses also behave as good as the other multifocal or even better. That means the glare and halos will be much lesser with this all these lenses because of this special greatest technology that is called smooth microphase technology. This is about the injector, blue cert injector. So this the video to the first lens I have implanted in India. So of course nowadays everybody is a very good surgeons. So do a good rexis, always around 5.5 rexis is the ideal rexis, and we do it with a 2.8 mm, 2.2 entry. I do phaco with the cautery system from the Zeiss, which has got something a unique system. So I just forwarded the video. So I do with the coaxial to remove all the cortical matter. So fill the AC with the viscoelastic, and also this is the injecting system comes with directly from the factory. So first inject the visco over the lens and also from the tip, then go and inject directly straight inside the bag. So very easy and smooth injecting system. So whenever you are taking out the visco, make sure that the viscoelastic should be taken completely from the antechamber, even from the behind the lens. So this is the one defocus. If you could be able to see the defocus curve, this is the one study I picked from Europe. The very smooth defocus curve. That means the patient has continuous range of vision. So in conclusion, trifocal intraocular lens implantation can perform by any cataract surgeon who is aware of the principles of refractive surgery and handles precise IOL power calculation. AT Ilana demonstrated excellent functional vision at distance, intermediate and near in our clinical evaluation. Almost all 25 patients, we have done a 25 patient around 50 lenses, enjoyed spectacle independence after AT Ilana implantation in this clinical evaluation. More results and long-term follow-up needed to substantiate the outcome. I thank Reena Madam and the entire team of the Arun Shetty Sir, Arunodaya Hospital for giving me this opportunity. Thank you, Ananda.
Thank you so much for the lovely talk on this newer Zeiss lens, and I'm sure you have a lot of experience in that lens, and thank you for sharing that experience. Any questions from any of the panelists?
Oh, our Terminator is Rajendra Prasad is also here.
I'm
Good
sure he
evening,
has a
Dr.
question or
Arpi.
two for
I'm
you.
here after the big boss, don't worry.
Okay,
So,
I
Dr.
think
Krishna, actually, you have shown very nice presentation on this lens at Lena. So, actually, in trifocal lenses now, these days, we have so many, we are already shifting from the trifocal to now EDOF and advanced monofocals because in my practice, I have almost left these trifocals now. The biggest problem with the trifocal, which we come across in our clinical practice is 90% of the patients, they complained the contrast loss for the distance. So what is your experience with this lens?
See, first of all, pre-op workup with this trifocal is very, very important. See, I always look at first start with the torchlight examination. I look at the mesopic and scotopic pupil size. If the patient pupil size is small, then normally these ring lens do really well, no glare and halos. But if the pupil size is very big, if the patient is having like when you put the torchlight, if they're having a pupil size around 3.54 mm, these are the patient we should go without ring lenses, more probably due to this EDOF lens do well. But patients, if their pupil size, if they are having some patients in even in undilated, like a very small pinpoint pupil they'll have. They never have a glare and halos. Such patients, these are the patients ideal candidate for trifocal. But if the pupil size is abnormal, of course, you need to do. We have got gadgets of investigation. We do everything like we do eye trace. We look at the angle alpha. We look the all other factors. If it is plus, then only we select them for trifocal. Or otherwise, I go for EDOF lens. But this particular lens I used that minimize the glare and halos compared to any other trifocal. What I have observed in my 25 patient result. Long-term results yet to know that, but definitely because of that technology from the lens, the glare and halos has been minimized.
yeah, I think selection is the most important criteria in these, and their counseling is utmost important. Thank you so much, Dr. Gunu, for your
Pre-op
beautiful
workup, I
presentation.
spend 20 minutes, madam, with the patient.
Yeah,
20
yeah.
minutes,
That's very good.
I don't hand over to anybody.
Okay, good,
True.
great. Thank you so much. Thank you. I think Dr. Rohit Omprakash is busy. That's what we got to know just now.
Thank you, madam. Thank
He's busy with some meeting. He'll be coming with us later. Is Dr. Bhasin there?
Yes, yes,
Okay,
I'm here.
great. Thank you and welcome and a happy day to you.
Thank you.
Let's hear him out with managing challenging subluxated lenses, the decenter dangling, no, but just the managing of the subluxated lenses.
Yeah. Yeah. Can you see my presentation, please?
Yes,
Is
we
it
can.
vis-
Yes,
Yeah.
we can.
Thank you. And I really appreciate the congress which you are doing on web platform. You and Dr. Sethi and and your son, really very nice Pan Ophthalmologica, very nice name. And I wish everyone a very happy World Sight Day. Aditya, how are you?
Great, sir.
Yeah. So, subluxated cataract has always been an enigma to all the cataract surgeons, and its management is a bit challenge, which we feel. And I am Dr. Purendra Bhasin, so I will be sharing my experience of managing subluxated lenses by FACO. And I don't have any financial interest. I practice at Gwalior, which is in the central part of India. And I really appreciate the Pan Ophthalmologica the program, the concept, everything. So without much ado, I will come directly to the videos. So this is a subluxated lens with the vitreous in the anterior chamber. As you can see, there is a traumatic cataract. I've pushed the triamcinolone, which is diluted, to see if there is any extra amount of some extra vitreous is present even after doing vitrectomy. So here I'm doing the capsular axis, as you can see, with the help of a microforceps. And this capsular axis is made centered to the center of the lens. And now with the help of capsular retractor, I am pulling it and fixing this back to the sclera. So now this acts like a zonule, and you can see well that I have been doing the PC polishing. Nothing has happened to the capsule margin. My capsular axis is still intact. It doesn't tear off. Here I am making a scleral tunnel. This is a reverse scleral tunnel, 1.5 to 2 millimeter away from limbus. 27 gauge bent needle is passed through the small scleral tunnel, and proline suture straight needle is passed from the opposite side to the main bone. And this is my section. The clear corneal incision is enlarged to 2.8 millimeter to accommodate the extra haptic of the Sioni ring. Sioni ring is brought, rotated to the area of maximum zonular dialysis, and the proline suture is tied to the sclera in the scleral tunnel, and the knot is buried in the scleral tunnel. So I'm removing the viscoelastic, and the vitrectomy is being done. The patient had a traumatic mydriasis. So with the help of this vitreous cutter, I am aspirating, and I have pulled the pupils, the iris margin, and reduced the size of the pupil. So pupil has been brought down, and this is the end of the surgery. Another case with a grossly subluxated lens. Lens is subluxated more than 270 degree. Capsular axis is made centric to the subluxation, and we should have a broad rim of anterior capsule to accommodate the capsule retractors. Otherwise, they will come out of this, and they slip out of it. And this is a double Sioni ring, means it has two extra haptics. And this is pushed inside. Mind it that when you are pushing this, your capsular bag should also be inflated, and the anterior chamber should be inflated with the viscoelastic. And you should plug the area of zonular dialysis with the help of viscoelastic, high viscosity viscoelastic. It is a bit cumbersome to pass two proline suture from the two ends of the extra haptic of the Sioni ring. And this is the post-operative picture, well-centered lens, well covered by the anterior capsule, and the two Sioni ring haptics are also visible. Another very interesting case, 32 years old female. She came to us with a history of defective visions for last 9 years in the left eye, and the refractive error showed this. The important thing is that there is a reflection of 4.5 diopters of astigmatism, and the best corrected vision is 612. So we did, and she came to us for the refractive correction, LASIK treatment, which was suggested by someone else. So on further examination, we asked the patient to get a tomography done. So on Pentacam, there was no cylinder, no corneal cylinder. So I was surprised. So why there is no cylindrical power in the cornea? We repeated, and still it was the same. So then we dilated the patient, and then we found that there is a nuclear sclerosis grade 2 with posterior subcapsular cataract, and the lens is subluxated. So retrospectively, she gave the history of trauma 11 years back. So we planned for a laser cataract surgery assisted phacoemulsification. And as you can see, with the catalyst system, we have made a 4.6 millimeter size eccentric capsular axis central to the subluxated lens. In a similar way, I have created a tunnel to fixate the lens back to the periphery, and the anterior capsule is removed. The most difficult part is to do the capsular axis, which has been done by, helped by the femtosecond laser. The nucleus is also partly softened with the help of laser, and the nucleus and cortex is removed, and some vitreous zonules were also there. So we have cut it and removed with the anterior vitrector, and the CNU ring is placed in the lens bag, and lens is placed in the bag. The conjunctiva is reposited and cauterized, and this is the patient, and this is the post-operative picture of the same patient. Patient vision improving to 6/9, and well-centered lens. Another case of similar type. In such cases, it is really helpful if we do a laser cataract surgery, because the lens is emulsified, and the most important thing, which is capsular axis, is central, and it is possible. Otherwise, because of the laxity of the capsule, because of the absence of zonule, the anterior capsule of the lens is very lax. So it becomes difficult to do the anterior capsular axis in such cases, and which is challenging. And if you have a laser, then it's better to do it unless until it is grossly subluxated. So procedure is same. We will fix the lens bag to the periphery first, and after pushing the CNU ring inside the capsular bag, and then phacoemulsification is done. So this is how the case is completed. So this is another interesting case with a grossly deformed lens bag. So this is a long-standing, there is a long-standing history of trauma. So the lens is partly absorbed because of the absence of zonules in that part. So you see that I am going underneath the behind the iris, and then completing the capsular axis, but it is possible. Otherwise, if you make a small capsular axis, then it will not be easy to enlarge it later. Then with the help of Sinskey hook, I am pushing the CNU ring in the bag, and with the bimanual technique, I am using two Sinskey hooks. You can see one is Lister hook and one is Sinskey hook. I am dialing the CNU ring inside the bag with difficulty, because this lens bag is small, and now I have pushed it inside. Needle is slightly bent because it is not exactly 180-degree opposite side on the opposite side, so I have to pass it at nearly 90 degrees. So I bend the needle and pass the Prolene suture through the scleral tunnel and tighten it, and the lens bag is pulled towards that side and stabilized. So once the lens bag is stabilized, then it is very difficult for the bag to decenter, and the vitreous loss is also avoided or was also prevented. This is kind of a nightmare which we had. So as you can understand, I have been doing this, following this technique for last 11 years, and I have done hundreds of these cases by this technique. So this was a grossly subluxated lens. So I have used nearly 5 rings. It is subluxated in this region also. So 5 capsular hooks, and the cataract is also dense. As you can see, it is a grade 3 to grade 4 nuclear sclerosis, and mind it, I do phaco chop. In these cases you can perform by any of your technique which you are comfortable with, and then we pass the suture in a similar way. Now you have to focus it here. So I have tightened the first knot, and which I do routinely. But at this place, you see my suture was too tight, so I have created zonular dialysis on the opposite side, which was having intact zonule. This side already the zonules are lacking, so I waited for some time, but my ring is in the lens bag. So that is the thing. So what I did, I cut the suture and passed another suture with 2 straight needles. So one of the needle has gone through the eyelet of the ring haptic, and the other from above, and both the end of the suture were tightened outside, and then I found that there is a rent in the posterior capsule also. So what I did, I placed the haptics of this 3-piece lens in the sulcus and engaged the optic of the lens in the anterior capsular axis. This is the margin of the capsular axis, as you can see here, and this is on the opposite side. So lens bag is stabilized, and we have a sufficient amount of capsule to so that the lens will not fall back in the vitreous cavity, and and the lens will not slip into the vitreous cavity because the optic is engaged in the anterior capsular axis. So this is the post-operative picture. This is the rent. This is anterior capsule, and on the other side. So this is stable. This is a post-op 1 month picture, and this is the area of zonular dialysis. So lens is stable. Patient has, and this was done nearly 4 years back, and the patient has not come to me after that. This case was done recently, some 10 days back only. Traumatic cataract, you see rosette cataract, and subluxated lens. It's a case of closed globe injury, which lands up in a similar way in a major good number of cases. And with the help of micro Caesar, keeping the anterior chamber filled with the viscoelastic, and I have done the anterior capsular axis, and then after doing the hydrodissection, after completing my hydrodissection, as you could have seen the fluid wave, I have pushed the ring, CTR in the bag. So this is how the lens has become central, and to avoid further damage to the existing zonules, I have placed a capsule retractor at the capsular axis margin and fixed it. So capsule retractor work like our zonules. So they pull the capsule back to the periphery. Instead of pulling from the equatorial region, we are pulling it from the capsule margin. And mind it, the important thing should be kept in mind is that our chamber should remain filled with viscoelastic even when you are removing the irrigating aspiration handpiece or while removing the phaco handpiece. Simultaneously, after we keep the chamber filled with and the bag filled with viscoelastic. This will avoid further damage to the zonules and it will prevent the vitreous loss. A single piece lens is placed inside the bag. This vitreous strand is there. So I am doing anterior vitrectomy. I will be doing and finishing it and removing all the viscoelastic. So sometimes there is a damage to the iris. So in a similar way, we can do if we can finish the case and the lens bag is stretched and fixated to the sclera. This was some 6-7 years old case, which I am showing here. And when you are going sideways, then you bend the needle. And otherwise, if you are going just right across, then you can use a straight needle. And I'm suturing the iris to reduce the size of the pupil and avoid glare to the patient. So this is how we can decrease the size of the pupil. That can be done. To conclude, one can use capsule retractor, or if you don't have capsule retractor, you can use iris retractors also at the capsular access margin to fixate the lens bag till the time you are doing the hydro procedure and phacoemulsification. And more the zonular dialysis, more the number of capsule retractors are required. Maybe 2, 3, or 4 capsular access, or even 5 capsule retractors. More than 3 clock hours zonular dialysis, one should fixate the lens bag to the sclera. Otherwise, if it shrinks or contracts in the due course of period after many years, after a few years, you will find the whole lens bag along with the CTR is shifted to one side. CTR or Sioni ring in the bag facilitates safe and successful phacoemulsification in subluxated cataracts, and fixating the lens bag helps in maintaining the lens well centered even after many years. One should be prepared to convert to SF IUL, glued IUL, AC IUL, or iris fixated IULs. Thank you for your patient hearing. This is a beautiful fort of Gwalior. I request everyone, if they should come over, be my guest, come to Gwalior for visiting this Gwalior fort. Thank you. So friends, our ultimate goal after all is not a good death, but a good life to the very end. This is what the physician Dr. Atul Gawande from US says, and I believe in that whatever you do with good zeal, so that the patient should not have problem in immediate or late post-operative period. Thank you.
Thank you very much, Dr. Vaseem. Wonderful presentation, and what a plethora of different difficult cases you have of subluxated. I don't think we witnessed so many. Thank God for that. The traumatic case, and especially the case which had the PCR, and then you managed so well. I think it's kudos to you. Very good cases, Doctor.
Thank you, ma'am.
And
Thank you.
I'll request, thank you, and I'll request Dr. Aditya to please introduce our next speaker.
So our next speaker needs no introduction. He is my teacher as well. It's Dr. Mohan Rajan, and I think his topic is absolutely apt after this particular talk we had. It's about after you place the IOLs in such capsule bags, about dislocated and dangled IOLs. So over to you.
Can I start?
Yes, sir.
Thank you, Aditya, and thank you, Reena. Hi, Arun, and in the entire team of ADEH. It's probably the best eye hospital you can ever see. The family is really fantastic. They're doing great service. And on this World Sight Day, I would like to acknowledge the efforts taken by each and every member of ADEH in eradicating blindness in this part of the world. And Purindra, I was amazed to see your videos. What
Thank you.
quality, really fantastic. And I was very happy that I could see your hospital last week when I was in Gwalior. Amazing.
Thank you.
And you're running out of space for that's one thing for sure. And so much of crowd. And I was just about to tell you that if you have any excess patients, you can send them over to Chennai to me. Okay.
Sir, looking forward to see you at many other platforms. I am really obliged and humbled to have you
Yeah,
at
I'll share my
Gwalior.
screen now, Reena.
Yes, please. Thank you.
Yeah. You're able to see my screen?
Yes, we are.
Okay, my talk is 3D, that is dislocated, decentered, and dangling IOLs. Okay, let me thank the Pan Ophthalmologica again for the wonderful opportunity. So these are the very common issues we are facing now, especially post-COVID. We are seeing this decentered lenses, dislocated lenses, that is called the dead back syndrome, and the dangling IOLs as well. So I'm going to show you a couple of cases. One is an ab interno fixation of a dislocated different approaches. This is a 70-year-old male, history of phaco-foldable 15 years back, 6'9" vision. He was complaining of oscillopsia. This oscillopsia as if he has taken a couple of pegs of whiskey and it was moving around the entire image. History of blunt trauma and pseudo exfoliation also present. You can see what's happening to this lens. This is a multi-piece lens done about 15 years back. It's an MA60 lens and the entire bag you can see here it's moving around. This is called the pseudophacodonosis and this was creating the oscillopsia. So since it's a multi-piece lens, we thought, okay, let us try and fix this multi-piece lens. Okay, and one of the most important factors in a glued IOL surgery is to do what is called an anterior chamber maintainer or a pars plana infusion. Okay, either you can put a pars plana infusion with a trocar and cannula, or you can have an anterior chamber maintainer in the then you create a flaps 0 to 180 degree. Then you completely strip off this lens from the cortex and the capsule, and you do an anterior vitrectomy as well, and then making sure that all the capsular remnants, the cortex, everything is removed. Then the anterior vitreous is also done. The anterior vitrectomy is also done. Catch the tip of the haptic and pull it out through the micro forceps there, the MST forceps or the epsilon forceps, which is a glued IOL forceps, which is available. Again, catching the tip of the haptic, don't catch the middle, and then try to take it out. Then once you externalize the haptic, then you have to do what is called put this in the tunnel that is called the Gabor-Charrier tunnel, and these are the flaps 0 180 degree. And once that is done, making sure that you have to put tricot and see whether you have any remnants of the vitreous in the anterior chamber. Put an air bubble, make sure the entire thing is dry, and then put the fibrin and the thrombin glue, and then close the flap and close the conjunctiva also, and making sure that everything is fine, making sure there's absolutely no hypotony at the end of the surgery. So this is the match is over now. I can see the postoperative results, 6/5 vision, but absolutely a steady lens. You can see the patient is moving. You can see 2 sutures there. That's not a problem at all. 6/5 vision this patient has got, and the patient is quite happy as well. Now you can see another patient with the glue IOL, wherein there is a decentered lens. Okay, the problem with these multi-piece, when you have a PCR, and if you put a multi-piece lens in the sulcus and leave it in the sulcus, there's a possibility of a decentering either in the short term or in the long term as well. So you need to make sure, and also producing UGH syndrome. So again, the same principle is applied, 0 180 degree flap. Either you can have an anterior chamber maintainer or a pars plana infusion. In this particular case, we just use some viscoelastic. We are just using small incisions. You can see that using a 26 gauge needle, we are stripping the entire lens of the cortex and the capsule, and you can see here, and then I'm putting an anti-ACM now, and then I'm catching the tip of the haptic and externalizing, and the rest is the same story as well. This is a 1 month post-op, 3 months post-op with an excellent vision. Again, another patient you can see here, one of my colleagues, he had a PCR, one of my postgraduates, and the PCR and the lens is put to the sulcus. Again, you can see I'm doing a vertical glued IOL, and because the patient, this thing is, I think you can either do vertical glued IOL, that is at 12 and 6 o'clock, or the 3 and 9 o'clock, depending on whatever convenient is this thing. And you can see here, and the most important thing is to making sure that the anterior vitrectomy is done. I don't want any vitreous or capsular or cortical remnants to come into the way. So when you have a PCR, you can see this is the posterior polar cataract. When you have posterior polar cataract, okay, or any PCR for that matter, you're putting a multi-piece lens in the sulcus. Once you put a multi-piece lens in the sulcus, what you do is you capture that optic into the bag. This is called the optic capture or locking the lens for that matter. So this is the optic capture. This will ensure the lens is right in the bag, number one. It prevents a long-term decentration of these lenses, and also make sure that the UGH syndrome is not there. The end point of the optic capture is the ovalization of the capsulorhexis margin, as you can see here. So this lens is very well captured. You can see here 2 months, 9 months, 5 years, the lens has not moved a micron. But if you leave it in the sulcus, and you can say, especially for patients who got high myopia, it can decenter over a period of time. It can also cause recurrent uveitis and glaucoma as well, and pigment dispersion also. This is another patient, 63-year-old male, drop in the vision, 6 months duration, tennis ball injury, dislocated IOL back complex. You can see here. You can see here what is happening. This is a single piece SA60 lens. Okay, obviously when it's a single piece SA60 lens, you cannot do the glued IOL technique for this. So we have to go for a different. You can see here the entire IOL back complex has completely decentered or subluxated for that matter. So this is the Hoffman's pocket which I create. What is this Hoffman's pocket? We start from the cornea and go back. Unlike the, so we don't open the conjunctiva at all. There's no peritomy. There's no scleral flap. So we use a scleral, that is a crescent knife, and make tunnels from the anterior to the posterior. That is anterior from the starting from the cornea. Then I put a 10-0 or a 9-0 proline suture with a long needle there, and one of the bites go in front of the haptic, the another goes in below the haptic as well. You can see that it's a double arm needle. So I bring it up, and through the Hoffman's pocket, I bring this suture up. Similarly, I do it on the other side as well. The pupil is small. Ideally, I should have used some iris hooks also, but I thought I'll be able to manage it. You can see this 26 gauge needle goes underneath the haptic, one of them, and then we do the railroading of the proline suture, and then it loops, the proline suture actually loops the haptic into the with the capsular bag. So in this case, you don't have to remove the capsular bag. The entire capsular bag gets fixated to the sclera. So that is the main advantage, this thing of when you do the single piece lens. You can see that now the lens is well centered, and you can tighten on both sides. And the advantage of Hoffman's pocket is that you don't have to open the conjunctiva. You don't have to make a scleral flap. Just make the scleral pockets on either side, the Hoffman's pockets on either side, and then try to put the thing and bury the what you call suture into the Hoffman's pocket as well. This again, can see here, this is a single piece hydrophilic lens. Okay, the single piece hydrophilic lens is a total different ball game. I didn't realize it. This patient came during the COVID time. You can see this again spontaneous dislocation, or the what do you call decent subluxation of the IOL. This is something like a Rayner type lens, hydrophilic lens. So I tried to do, I thought I'll do a what do you call similar to the previous surgery. I thought I'll be able to do a fixation. So I used the Gore-Tex suture, but you can see what is happening because it's a very lens is a very slippery, and I think actually it's a mistake by doing this what do you call the suturing of this lens. into the sclera as well. The whole lens started sinking southwards and started going into the vitreous cavity as well. And then I did what is called an anterior assisted levitation of the IOL. And the anterior assisted levitation of the IOL, you can see here, bring the lens up and then bring it out through the corneal scleral incision, and then I do an anterior vitrectomy, and then I do a glued IOL in this case as well. You can see here another patient with the dislocated lenses. Again, you can see here this is a patient who had for a supraphobe lens, I was using the Alcon injector. Don't use one lens for another injector, and this is what will happen. Suddenly there is the lens came out with a jerk and ruptured the PC, and the whole lens started sinking into the vitreous cavity as well. Then again, I went through and brought about the all technique. What is this all technique? Anterior assisted levitation of the intraocular lenses, or the AAL. Okay, you can see here I'm through the side port, right side port, I'm bringing this lens up. And since it's a supraphobe lens which doesn't have thick haptics like the SA60, I was able to keep this lens in the sulcus because the capsular rhexis was quite intact as well. Again, another patient who is totally dislocated IOL into the vitreous cavity with the bag. This we see very commonly now, especially a spontaneous dislocation, especially patients with the pseudo-exfoliation syndrome. So this to show you because the picture is not very clear here, and you can see here because of the corneal edema in this particular case, and how I'm removing the nucleus and the lens from the vitreous cavity as well by doing a vitrectomy. This is another patient wherein we had to remove 3 IOLs from the same patient. The IOL number 1, an anterior chamber IOL, and then IOL number 2, wherein there was a single piece, there was an acreose IOL in the anterior vitreous, and then another IOL which is a single piece lens, which was there, single piece PMMA lens, which was there, IOL number 3. Apart from that, the patient also had a CTR and a nucleus piece also. Again, you can see here this is an IOL repositioning using a Gore-Tex suture. You can see Gore-Tex suture I'm using. The Gore-Tex suture nowadays we use the Gore-Tex suture. The advantage of the Gore-Tex suture is that it's not biodegradable like the Prolene suture, because we see some Prolene cases after about 10 years or 5 years or 10 years, it degrades and the lens again dislocates into the vitreous cavity as well. Where the Gore-Tex sutures don't dislocate. The problem with the Gore-Tex suture, it's a little big. It's about 6.0, and this is a problem. But I'm able to, again, this is a single piece lens. Again, it's an SA60. I think it's an Alcon Acrisoft lens, IQ lens, as you can see here. So the Gore-Tex suture, one suture is passed underneath the haptic, another suture is passed, another end of the suture is passed above the haptic, and the entire haptic is looped up. And you can see here, I'm taken a scleral flap 180 degree, and again doing a sclerotomy on that side, and then passing the suture. One suture passed in front of the haptic, another suture below the haptic, and passing through getting it through the sclerotomy and tying it on both sides, tightening and loosening depending on the centration of the lens as well. And these are the ways by which you can see you do the Gore-Tex suture also. Again, this is again another patient wherein the nucleus is gone into the vitreous cavity after a PCR, eventful cataract surgery. And you can see here what I'm trying to do is I'm doing what is called an X-net technique. Again, the 180 degree. In all these SFIOLs, you need to make sure that the axis is correct, that a 180 degree axis is correct. Then I'm making a what you call with the 15 blade, I'm making a not a 15 blade, 15 degree knife. I'm making a tunnel there, something like a gauche tunnel, and then I'm passing a 26 gauge needle, and through the scleral incision, I'm passing a multi-piece lens. This is a multi-piece lens. You can either use a sensor acrylic or an SA60. I'm sorry, the MA60 or an Aurolab multi-piece lenses are also available. And this is called the X-net technique, which has been popularized by the Aravind group and the Pondicherry group. And you can see here how I'm bringing that lens, externalizing that haptic, and then burying that haptic into the tunnel. There is no glue you used here. So the haptic just stays in the tunnel, snugly fits into the tunnel, making sure that the tunnel is not very big. Otherwise, there's a possibility the haptic can slip out of the tunnel as well. Again, you can see another patient wherein the IOL bag complex are dislocated into the vitreous cavity. So again, I'm trying to do a thing. Obviously, this is a single piece lens. The whole IOL bag complex is gone. 180-degree rectangular flap. I'm putting a pars plana infusion there because I had to do a vitrectomy, 3-port pars plana vitrectomy, and this is a 25 gauge vitrectomy system. And then I'm making a scleral tunnel in this case and going inside, and you can see that the whole thing is there. You can see the whole IOL bag complex has got dislocated. It's lying on the macula as well, and making sure that you do a total vitrectomy, induce a PVD, making the lens bag complex completely mobile. Otherwise, there will be traction on the vitreous, and you can produce retinal detachment, retinal breaks also. I'm bringing it up with the flute needle and with the passive suction, and the whole thing is coming up. I can see here. Obviously, we need to explant this lens along with the bag, and then we go ahead and put a glued IOL in this particular case. So whatever you're comfortable, again, we have to make sure the remaining amount of cortex and whatever this thing is there, you have to this thing, and then you make a sclerotomy and then go with a multi-piece lens. And normally I use a sensor acrylic lens. You can go through a foldable lens, asking your assistant to inject the lens, and then as the lens comes out, making sure that you catch the tip of the haptic and bring it out, and then externalize, and making sure that you put it in the tunnel. And exactly, this is called the Gabor-Shiré tunnel, which we create. And sometimes, many times, we stain that Gabor-Shiré tunnel with a trypan blue to make sure the tunnel is visible as well. Again, you can see these are the various presentations I have given you. There are many ways to skin the cat, but obviously you need to decide on the table. And you can even do retro iris claw fixation of the IOL as well, or even anterior chamber IOL if the corneal endothelium is fine, making sure that the anterior the vitrectomy is done well, the pupil is round, and don't forget to do an iridectomy in an iris claw or an AC IOL for that matter. So thank you very much again, Dr. Reena, Dr. Aditya, and the entire team of ADEH for consistently delivering all these webinars on the World Sight Day. It's become very popular now, I know. Please email to me at drmohanrajan@gmail.com if you want a copy of the color atlas of the retina and the optic nerve and the color atlas of the cornea. And please send your full address and your phone number as well. We'll be able to send it to you. Thank you very much.
Thank you so much, Dr. Mohan Rajan. That was really a 3D presentation. Wonderful. And one couldn't have handled so many cases in so many different ways. Thank you for showing them all to us. Thank you.
Thank you.
Dr. Aditya, kindly introduce the next speaker.
Our next speaker is going to talk on a very relevant talk. It's about IFIS, and we have Dr. Rohit Om Prakash sir, all the way from Amritsar here. Looking forward to hearing what he presents on IFIS. Over to you, sir.
Can you hear me?
Hi, Rohit.
Yes, sir.
Hi.
Yes, absolutely. Perfect.
Yeah. So let me share.
Perfect, sir.
Yeah. Can you hear me too? Yeah.
Yes.
Initially, at the very outset, I would like to congratulate Dr. Mohan Rajan for his excellent talk, as usual. So I've been asked by Dr. Reena to take up a very interesting scenario, which is the IFIS. And I would like to put across, the missing link, which I feel is the way how we can decode it. So I have nil financial disclosures relevant to the subject matter of my talk. So let's see this situation. Can you see it? Am I audible and everything? Yeah, should I continue?
Yes, sir.
Yes, you're right, yes.
Yeah, absolutely. So this is a patient who is on alpha-1 antagonist drug. And the moment, we try to, let me get back. I think there's some, yeah, now I'll start. So in this patient who is on alpha-1 antagonist drug, what has happened is that, the iris has started coming out through the primary incision and the pupil has also started getting smaller. And in this patient, you will find that the iris has started coming out through the side port incision. So that is another thing which has happened in this patient. So this is because the side port incision was larger than the iris. And in this patient, while trying to inject in the visco, the iris has started coming out. And in this, while doing hydrodissection, the iris has started coming out. So these are the different situations in which you will find that we see patients who have intraoperative floppy iris syndrome. So now the question is, so what is the basic problem in these patients who are on alpha-1 antagonist drugs?
We are not able to see your presentation, sir. Yes, sir. Now we are. Yes, sir. Yes, sir.
But is it okay now?
Yes, sir. Yes, sir.
Yeah, perfect. So what happens in these patients is that because of blockage of alpha-1A antagonist drugs, adrenergic receptor, which get blocked, and these receptors are basically present in the dilator muscle of the iris. Now, what happens with all these things is that there is a reduced maximum pupillary diameter in these patients. And another important thing which we realize in these patients is that the dilator muscle region is thinned out and atrophic. And now what happens in these patients is whenever there is a fluid influx to the posterior aspect of the iris, we find that there is iris billowing. So this is one thing which we have to bear in mind. So now what really happens in these IFIS patients is that there is iris billowing and fluttering. There is a tendency for the iris to prolapse, and there is progressive constriction of pupil. So it has been shown by, Alessandra, that in these patients who have a pupil of even 7 or small, there is a risk for IFIS. It exists regardless of the, alpha-1 antagonist drugs which are used in these patients. And there's another, the publication by David Chang, in which he has seen that when we use Maliguin ring pupil extension device for intraoperative floppy iris syndrome, there's no second thought that 6 millimeter pupil is sustained throughout the surgery. But we have to realize that there were no significant intraoperative or postoperative complications, despite the fact that 93% of the eyes had moderate to severe intraoperative floppy iris syndrome. So this part also we should be able to understand. So now let's see what is the surgical technique which should be undertaken in these patients who are on alpha-1 antagonist drugs. So this is a blue-eyed patient whose pupil size is 5.25 to 5.5 or maybe less than that. So, I personally believe that, we should definitely have a strategy which should help us in all scenarios to take care of intraoperative floppy iris syndrome from happening. So in this, the first and foremost is the incision. The incision which is, which is tried in this patient is a long and narrow long and narrow interior incision. So that is something which has to be tried in these patients. The next part is, we should definitely try to use intracameral epinephrine. Well, we have to realize one very important factor, that the role of adrenaline or epinephrine is becomes restricted in those patients who have been on alpha-1 antagonist drugs for a long time. In those patients, these, they become atrophic, so they do not, the receptors become atrophic, and there is no effect of adrenaline or epinephrine on pupil dilatation. So this works when the the receptors they have not become atrophic, or there is no total atrophy of the muscle. So next point which we have to see is that we have to use this is the viscoelastic which I'm going to use. In my practice, the viscoelastic which I use is a viscodispersive one. And one has to be very mindful in the way one uses the visco in these patients. You will find that I'm not trying to overinflate the anterior chamber, because in these situations at times we can end up with an iris prolapse. Steve Urchinov has shown that one can use trisoft shell technique, wherein he uses a viscodispersive, a viscocohesive in the center, and then so that he's able to avoid intraoperative floppy iris syndrome in those patients who are predisposed to having an IFIS. So next, which I fashioned was a side port incision. A side port incision should be used in these patients. So it should be a narrow side port incision. So this is the side port incision about which I'll be talking as and how I move, how relevant the side port incision is. The next part is the sizing of the capsular axis. This is one basic situation where the sizing of the rexes in a small pupil should be less than the size of the pupil. So here I'm going to fashion a capsular axis which is smaller than the size of the pupil. Now the question is, why do I want to have a small rexis? Well, the answer to this is because with the capsular axis rim all around here, there is no excess of fluid from the bag to the posterior aspect of the iris, which helps in decreasing iris billowing. So the pupil size in these patients, the capsular axis size in these patients should be smaller than the size of the pupil. Otherwise, in all patients who have a small pupil, what we have been generally taught is that we should have a capsular axis which should be larger than the size of the pupil. Next, the hydrodissection has to be slow, has to be guarded, because at times we can end up with a situation wherein we can have an iris prolapse. Ophthalmologist from Bangladesh, he does hydrodissection by using the sleeve so that there is no space for the fluid to come out suddenly. So he uses the hydrodissection cannula fitted into a sleeve so that there is no clear area in the primary incision for the fluid to have an excess to come out and cause the iris to prolapse. So that is another important thing which we have to bear in mind. So next is the fluidics which we have to use. In these, just see how I have taken it in. I have taken it with irrigation off in, and once I'm inside, I have just started it, and see the fluidics which I'm using. I'm using low IOP fluidics as has been shown by Robert Osher, because with these low fluidics, I'm trying to create a situation in which there is less amount of turbulence in the anterior chamber. So this is something which is basically the aim, going in with irrigation off, using low fluidics, so that we create a situation in which there is less turbulence. So I am doing things and keeping the phaco. Just see the side port incision. With the side port incision, there is a flux of fluid, but there is no undue efflux of fluid through the side port incision. And I'm keeping everything in the center, irrigation off, and I'm coming out. So this is how you have to do this in these patients, and you will find that the size of the pupil is the same. Now irrigation off, I'll go in, and then irrigation off, I will come out. So these are the things which we have to bear in mind. So we published the use of narrow calibrated side port technique to prevent occurrence of intraoperative floppy iris syndrome during phacoemulsification surgery. So this is the thing which we have to bear in mind, that we should never consider a side port incision, rather a side port incision, and we should not give due regard to it, because at times it so happens that it is the side port incision which creates a problem, because in these patients on intraoperative floppy iris syndrome, in those patients who are predisposed, the iris muscle tone is, dilator muscle tone is decreased. So whenever there is a small touch, what happens is that with this small touch, because of the less amount of dilator muscle tone, an unrestricted pupillary constriction occurs. So we have to bear in mind that the techniques have to be such that there should be less amount of iris touching during the whole procedure. And what we realized is that I have seen so many videos across, and I found that surgeons are not calibrating the side port incision, as in the one I showed right in the beginning. Because of the trauma, what happens is that the pupillary constriction starts from the side port incision and it spreads and the pupil constricts. So and this we published way back in 2019 also, about the use of calibrated side port incision. So yeah, this is what I would like you to show, to see what happens in these patients. The dilator muscle tone is less. So a small touch, it precipitates intraoperative floppy iris syndrome. So this is something which we should definitely bear in mind. So now the next question is, what does the narrow calibrated side port incision do? So what it does is,
there is no disproportionate
Can you
efflux
hear it?
of fluid to the side port incision. There is no iris undulation and billowing subjacent to the side port incision. There is no iris trauma. This sinking in size is allowing easy manipulations in the anterior chamber. There is no wound distortion. Surgical manipulations are easy. At the same time, there is no disproportionate efflux of fluid from the side port incision. There is no iris undulation and billowing subjacent to the side port incision. Consequently, there is no iris trauma and pupillary constriction initiated from the side port incision side. The question of iris prolapse from at least the side port incision doesn't arise at all.
The next thing you will see that these are two blue-eyed patients. The size of the pupil was the same at the start and at the end of the surgery. So, we found in our study of around 450 eyes, there was hardly any patient who had grade 2 intraoperative floppy iris syndrome. The grade 1 was because of billowing. So this is what it is. So we can at times end up with a situation wherein we can do all these things. But mark my words, what we have to realize is that we have to add this calibrated side port technique to the existing surgical protocols, which enhances their efficacy in preventing intraoperative floppy iris syndrome. So now let's see how we can combat this challenge, because most of us are using a bimanual technique of doing irrigation aspiration. What I suggest is that you should use a calibrated side port incision initially, and when you start with the irrigation aspiration, the bimanual one, you can enlarge the size of the side port incision. Dr. Gaurav Luthra, what he has done is he has calibrated his, side port incisions as far as the IA is concerned also, which gives a situation in which the side port incision and chopper has been calibrated. Now, what I want you to see is that the question which everybody should have in mind is, how do I calibrate my side port incision in my practice? Well, the most important thing which we have to bear in mind is, it is not only calibrating the side port incision, we have to narrow it down and calibrate it. What we have done is that what I use in my practice is, for the side port incision, I use a 500 micron, 25 gauge needle. So that is what I use. And the chopper which I use is 350 to 300 microns, right from the, from the proximal end, it is 350, and at the distal end of the shaft of the chopper, it is 300. Now the question is, how do we get it made? I have nil financial disclosures, but Sham from what do you call Epsilon has what should I say, calibrated the shaft in cohesion with the 25 gauge needle which I'm using. So anybody who wants to use a calibrated chopper, he just needs to tell him that this is the chopper I use. So he will let you have the shaft which he has made for the chopper, which is properly matched to the narrow calibrated side port incision, and the tip can be calibrated accordingly. So I would like to acknowledge the works of David Chang, Campbell, and Steve Oshinoff in this intraoperative floppy iris syndrome. Thank you so very much for your kind attention.
Thank you very much, Dr. Rodho Prakash, for a hand-holding talk. Each and every step was so brilliantly explained and displayed that it was like a tutorial, and it was very well presented.
The only thing which I would like to add is that whenever you find that the pupil size is 5, 5.5, if you want to use Malaguin ring, yes, go ahead. No second thought about it. I'm not trying to dissuade people from using a Malaguin ring. That gives you a very good security. But all said and done, my basic viewpoint is that you should know how you can use the technique of long, anterior tunnel, calibrated side port, use of visco, epinephrine, irrigation of all these things should be added so that you should have lesser amount of catastrophes when you are dealing with a patient who is on alpha-1 antagonist drugs like tamsulosin.
I'd like to ask Dr. Lisa Abiza, what is her opinion about this?
Can I make a comment, Sarun?
Yeah, please, sir.
No, beautiful talk by Rohit. Wonderful. I think IFS is a very major issue we are facing. Only thing is, what I would suggest is when you get the iris out, okay, don't try to push the iris through the main port. You will tear the iris. I've had a couple of instances wherein I had to cut a very sorry figure. There'll be a huge hole in the iris.
Absolutely.
You have that and go through the side port and try to use only viscoat for these conditions. Don't use HPMC.
No, sir. One can easily use, and I've never used it in HPMC, this viscoat or anything, whatever you are saying.
Yes.
And just that you use HPMC, but you should be very clear how you have to use it. You should overinflate. You should, start injecting HPMC right over the iris.
Yes.
So it's in the initial speed itself, it is pushed back slightly. And then you can inflate it, but don't overinflate it.
Overinflate. That's also one thing. And also making sure that when you come out of the eye or go in out of the eye, go without irrigation and come out without irrigation.
Absolutely.
Because when you come with the irrigation, the iris will also start coming along with you.
The Bernoulli's theorem comes into play. It follows you.
Okay.
Hi, Lisa. How are you doing?
Hi, I'm well, thank
Hi,
you.
Lisa, ma'am.
Very well covered. Very well covered. I might add that whenever you touch the iris, there's going to be more inflammation. And so if you do have, you want to be able to see it just come out of the internal valve of your incision and stop it there and then reduce the pressure. But if you do have any injury, it can help to use a little extra steroid, dilute triescence inside the eye if you have access to that. At the end of the case, will make a much quieter eye for you for the next couple of days early.
Yeah, another important thing which you can do is that if your iris is coming out again and again, just forget about that. Create another incision. So that also helps at times,
And what I do also is, Lisa, hi Lisa. Hi, how are you? No, I use a cotton bud. Okay. So whenever I come out of the eye, I don't know if you have seen my life surgeries. And whenever I come out of the eye, I just keep the cotton bud on the main incision. That will prevent the forward movement of the posterior capsule and the iris also coming forward in patients with IFS. So,
perfect.
Yes. Cotton bud. Of course, switching off the irrigation coming out, cotton bud.
The fluidics have also to be low,
Yes,
You cannot use, as has been shown by Bob Osher, because if the fluidics are high, when you will come out with irrigation on, that will create a problem. So you spend around 1 second more in 0.5 second with irrigation off and then come out.
Okay.
Right.
Thank you so much, and a very welcome to Dr. Lisa. Yeah, thank you, thank you. So is Dr. Rajendra Prasad ready? I think he's having some network issues. So can we get over to Dr. Saurabh but further, if he's ready?
Yeah.
Okay.
So sir's
Am I
going to talk
audible?
about rookies. Yeah, we can hear you, sir.
Yeah,
He's going
yeah,
to
yeah.
talk about rookie mistakes in cataract surgery. And for those who don't know, sir, he has a very live YouTube channel and is a teacher of cataract surgery for many doctors. Over to you, sir.
Yeah. Thank you, Aditya. So I will share my video. Is it visible?
Yes, it
Yes,
is.
sir.
Yeah. Is it full screen for you?
Yes, it is.
Yeah.
Okay. Okay. So I will go ahead. So this video basically, so far in the presentations, many times we see, stalwart surgeons operating with who have a lot of experience. But in this video, basically, I have collected a few cases where the surgeons are moderately experienced. Probably they are on the verge of starting, their independent cases. So this was the first surgeon who has experience of 200 cases. So probably just fresh out of a fellowship program or a PG program, and wanted to come and ask me to assess how his surgical skills are. So the surgery is doing basically independent surgery, and as you can see that though he has done good number of cases, probably he doesn't still know where to hold the flap. Like for example, he's still trying to pull the flap from the fold area rather than what I call rule of center of triangle, where you have to hold it at the center of the triangle of the cut flap, and then he should be followed. So many times uh, people feel that they have completed fellowship or they have completed the graduation. That means they know the surgery well, but sometimes it's very important to analyze what you are actually doing. So he did the first hydrodissection, which he thought was complete, and now he's trying to rotate the nucleus. But as you can see here, there is a lot of resistance to the rotation. Okay. So here, the surgeon should have immediately realized that the hydrodissection was not complete despite having a good wave. Probably he needs repeat hydrodissection, and that's what he did now. So, so that was the area where probably he was not good enough to analyze that the need of repeat hydrodissection. Now, watch here that he's trying to chop this grade 2 cataract, which is a good grade to start chopping. But if you watch on the left side hand side, he is not using adequate power initially. And later, when he was, nudged to start using power, he could then bury and do the chop. So what I found observing this surgeon is that he was not still analyzing his own surgeries. So though he was able to complete the surgeries, he was probably not good in analyzing. That's why his improvement was not as good for surgeon who might have, done in 200 cases. And he had no surgical recording system, so he was not using those either. So this probably for a surgeon who is initial in the beginning career will matter. Now, this surgeon is in the fellowship program. He has done almost more than 100 independent surgeries, and that's why he was allowed to do a surgery on his own. But now you can see if when we saw his recording, because there was a complication in this case, I found some simple mistakes being done. For example, he was hydrating the incision, and look at that. He hydrated or overhydrated, and then anterior chamber pressure rose, the iris started prolapsing, which he realized and burped out. But again, when he tried to inject OVD, again he did the same mistake of over injecting the OVD. So that indicates that he still has to develop those analytical skills. So he was making, creating problems and trying to solve it, but rather he should be thinking of how to avoid. Now here he again did hydrodissection, which was forceful, but again in this case you can see that he was using excessive force trying to make the nucleus rotate. Now in surgery, particularly cataract surgery, it must be understood that we rarely need such kind of force. In fact, we should not be using such force at all. Now he continues with the trench and divide, and this is a soft grade of cataract. So he plans to do trench and divide technique, and you can see that he made the division, but it was not complete. And when he tried to rotate the nucleus again, you can see that the nucleus is stuck. So immediately he should have realized that probably there is some problem with zonules already here, and still he's trying to force his way. Again, he tried to do another trench divide in, and you can see that the trench is too superficial. Now here, definitely his analytical brain has stopped working. So he's trying to finish off the steps rather than, going through each and every maneuver with, clear plan. So here you can see he is desperate to just emulsify the nucleus and not following any particular plan. He's just trying to use the quadrant removal settings with high vacuum, and probably here he has already created a PC rupture, but his whole focus is on doing the emulsification of the pieces. And here one piece goes down, and as you can see here, he just freezes in that moment because he has never had a plan what to do next and continues to FECO. So I think most important thing in doing each and every surgery is that you must develop that analytical mind. And whenever you are feeling desperate while doing any step during any surgery, that means you are doing something wrong. So that is a time when you must take a pause. And mindfulness during surgery is extremely important for beginners or intermediate or even for the most advanced surgeons. For example, this surgeon. Now, this surgeon has probably 2000 or 3000 cases she has done. And she came to, demonstrate the surgery. So she was given a couple of cases which she did very well. So now she wanted to do a difficult case, which was a small pupil case with a slightly harder grade of cataract. And seeing that she has quite significant experience, she decided to do it, and she was doing independently. But here you can see that the microscope is decentered, the pupil has come down drastically, but still she is trying to chop under this small iris or small pupil, and obviously she has not chopped it completely as well. There are no separate pieces, and still she continues to try to chop, desperately trying to emulsify the pieces again without any plan. Now, just to remind you, these are happening. Now, why these things happen with surgeons with, significant number of surgeons, operate on our own without anyone observing us, and we get through cases somehow. We call it do it somehow. Now, in this case, obviously, there was a PC rupture, which he realized. And while doing vitrectomy, rather than making another side port of adequate size, you can see that she tries to do the vitrectomy through the main incision, and leak is happening. And again, with lack of control over the vitrectomy cutter here, she cuts off the iris also. Now, why these things happen even with surgeons with fairly good amount of experience? This is called amygdala hijack. What is amygdala hijack? Whenever you are calm, composed, it is your higher cortex or the prefrontal cortex which is making the decisions for you. You have the rational thinking in place. But whenever there is you are high on emotions, it may happen during the surgery, or sometimes a VIP case, a case where you have to deliver very well, or there might be a case where many people are observing you. And in such high emotion state, sometimes the higher cortex may get disabled. And this is called amygdala hijack. Now the irrational amygdala takes over, and now the rational thinking goes out of place. Okay, so how to avoid that? You must understand this particular thing. whenever you are desperate to do any particular step, like you are feeling the desperation, take a pause. There is always a better way to manage that particular step. You must analyze that and then take a pause, just be emotionally calm, composed. And I'm sure that all of us can get through this. We can avoid this amygdala hijack and, bring this case to a logical end. Thank you so much.
Thank you very much, Dr. Saurav. I think it's very important to stay calm, cool. And one suggestion that is that all the time when you operate, you must have a nice soothing music in the operation theater that keeps a lot of doctors, surgeons as well also in good space. Thank you very much for all the various points you did. Thank you. So over to our next speaker. I have great honor in inviting Dr. Lisa Abizer. She's my mentor as well. And always so interesting to listen to her because there's always so many pearls that we have to learn from her. So she's going to be talking about short learning curve for lasting visual outcomes in cataract surgery. You need to unmute.
Yes, I just did. Yes. And let me share here and with sound. Share sound. Okay. And share. And hopefully you can see my screen now.
Yes, we can.
Okay, very good. From beginning. Let me move you out of the way here. Slideshow. Beginning. Okay, very good. So I appreciate very much the opportunity to speak again. I recently had the opportunity to come and watch surgery at the Sathis wonderful hospital, and what a team and what great work you're doing. It's a pleasure to be involved. So these are my financial disclosures. And as we all have seen, fibrotic after cataract lens epithelial cells develop that can cause phimosis, not to mention capsular opacity, and of course Elschnick's pearls, which lead to YAG laser capsulotomy. And I'm a firm believer, and really my quixotic goal here in my later years in ophthalmology is to try to convince people that it's worth keeping a two-chambered eye for life by keeping an anterior hyaloid and avoiding removing the posterior capsule. And Howard Gimbel first described optic capture, including posterior optic capture. Several people are expert at that. Menapachi did a spectacular intra-patient prospective randomized controlled trial that showed the lack of inferiority over 6 months with no increase in CME or pressure rise early or late. One vitreous prolapse in 150 cases, which he called a learning curve, and no increase in RD. They were only followed for 6 months, so many of the advantages that we might expect in the long run were not noticed. And this is a very important publication. I'll just go by quickly. You can take a photo. Now, what are the reasons to master posterior capsulotomy and, in fact, posterior optic capture? And one is to convert an unstable accidental tear in the PC for a stable implantation. Of course, we're all going to run into this situation, and hopefully we'll notice our complication early enough that we have something that can be converted into a CCC. I could talk for hours on the details of these subjects. Allow immediate visual rehabilitation in an unpolishable plaque. When we know that we cannot polish that plaque, but we could get around it with a rhexis, that means that the patient has immediate improvement in vision. And more importantly, rather than waiting 3 months or so to open the posterior capsule, to open that cloudy capsule with the YAG laser, which always opens the anterior hyaloid and creates a one-chambered eye. If there isn't total fibrosis already, we can avoid this situation and keep our hyaloid intact and not require a secondary surgery. For patients who can't sit for a YAG, these are the best patients to start on for your learning curve for posterior rhexis after you've hopefully practiced in maybe other model eyes or in a lab situation. For those patients, it's a huge advantage. For optic capture of subluxated intraocular lenses, sometimes we can't use the anterior rhexis for various reasons. And in order to have a truly stable lens, We can't put it in the sulcus, as was discussed earlier and appropriately, because it will almost always become loose. And if we can't anterior capture, then we can make a posterior rexus and posterior capture. Also, once we capture a lens, it can never rotate. So in a toric situation, it makes sense. So these are all reasons to master this technique, even if you don't intend to use it routinely, which I think is where our profession should go. Now, is it enough just to do the PCCC? Well, that's posterior continuous curvilinear capsulorhexis. Well, not really. In adults, it will vastly reduce the incidence of PCO. In children, it will not, because of the solid vitreous and the cells growing over the anterior hyaloid so easily. Now, we have to understand the retrolenticular space. And there's so little understanding of this. Marie-Josée Tassignon has taken literature from the 1800s and from her work with on this subject, and shown us we've learned more and more about Berger's space, which is delimited by Wigert's ligament. And our posterior capsule is not, in fact, the barrier between the anterior and the posterior portions of the eye, but rather it's the anterior hyaloid, which is. And there's lots to discuss and lots we're going to learn about Wigert's ligament attachments and not creating them with high parameters on our phaco machines, and we may learn the incidence with age as well. And this could very much impact some of the modern ideas for accommodative lenses, by the way. So once we understand that, then we know that we have a space we can depend on. And here's a rare and wonderful video from Tassignon showing her making an opening in the posterior capsule. It's this business of intraoperative OCT. And immediately that diaphanous vitreous face will kind of come forward, sometimes negating a true Berger space and making that potential rather than real. And so that's why next, after we start a little flap, we're going to use OVD. And you'll see with the OVD how the hyaloid is just pushed back without any pressure to come forward whatsoever. Just a little bit of OVD in that in Berger space will make that a very real chamber, and a Berger space, a very real space. And there doesn't tend to be any forward pressure like we sometimes have with an anterior capsulotomy. I've never seen any hint of anything like an Argentinian flag with a posterior capsulotomy, because that hyaloid is so diaphanous and just falls backwards. And you would never start a primary posterior rexus without first being sure that you have a capturable anterior rexus as your safety. Now we've seen her do that complete rexus following the cookie cutter, the anterior rexus, and how the hyaloid does not tend to come forward at all because of the OVD in that space. Just cohesive OVD is fine. Now, this is one of my first 5 cases. I'm checking that my anterior rexus is capturable to be sure that I have an option in case I have a problem. I've put OVD into the sulcus to make the 2 capsules planar. And now I'm using a bevel up 30 gauge needle to make a wrinkle in case the hyaloid's right behind it, and lift up a flap and begin that flap. You'll see later Menapachi, who is my mentor in this, teaching that he likes to even make a bigger flap, but that's as far as Tassignon tends to go. And then you'll watch this. Now I'm putting the OVD in, and you can see it fill into itself as opposed to drop downwards. We're hopefully soon going to publish about my plunge sign, where if it drops downwards, then the anterior hyaloid is not intact as you put that OVD through. It's even more obvious with a dispersive, but it's obvious with a cohesive as well. And now, because the posterior capsule is 4 microns thick as opposed to 14 microns thick in the anterior capsule, and more elastic, we're going to regress much more frequently, and we're going to go ahead and follow our cookie cutter design of our anterior rexus. It doesn't have to be quite as big because it's more flexible in terms of capture, and because of its elasticity. And we're going to have a more centripetal force. This is, very early on. I've got my heart in my mouth in doing these cases. I started in 1996 or 7 in order to do this for my pediatric cataracts and optic capture, and also for anyone who couldn't sit for a YAG. And now I'm putting the OVD into that spare tire of the fornix of the bag between the posterior rexus and the anterior rexus. And you can see that that is making a very good landing zone now for our three-piece lens. Although Jason Jones has shown us that we can use a one-piece lens with the refractive technology on it in this regard, there's far more opportunity for herniation of the vitreous around it because of the broad optic-haptic junction. And so I prefer a three-piece lens. Of course, we so far do not have refractive technology on that lens. And I'm hopeful that I can convince somebody, maybe that could be in India, to put the refractive technology on a three-piece lens, which we can assure will be centered, and Minapachi showed has a stable, effective lens position. So you can see I'm being very cautious. This is done in like a minute by people who are accustomed to doing it often. And as I got more facile, I got certainly more quick. Here I'm going to rotate that trailing haptic into the bag. And then, unlike anterior capture, where we just push on the pole 90 degrees away from the optic haptic junction and it kind of pops under that not very elastic anterior capsule, instead, we're walking it from optic haptic junction to optic haptic junction. We start 90 degrees away and then get it into the right place to be sure that we have that beautiful football shape that we're used to seeing with the anterior rexus from optic haptic junction to optic haptic junction. You can see my anterior rexus is undisturbed and my posterior rexus is now a beautiful football shape or cat eye shape. Now we only need, now this is my first few cases, so I used triescence after removing the anterior OVD, but that's of course not necessary once you're confident in your technique. So you want to be sure you never uncapture and you remove the anterior, all the anterior chamber OVD, but it is not necessary to disturb the capture and remove the posterior due to the fact that Minapachi has shown that that stays away from the trabecular meshwork and will not cause a problem. So here's Tassignon, takes her 33 seconds to get this done. She's done thousands of cases. You can see this is a pediatric where Wiggert's is definitely intact and she can fill with the OVD all the way out to Wiggert's ligament. That's usually not the case in our older patients, but where we've, especially if we've had a prolonged or high vacuum and aspiration case. And you can see that she gets that done very handily. And now I just want to allow Dr. Minapachi to teach you like he
Regular Helon is now injected above the anterior capsule leaf.
Can you hear?
In order to bring down
Yes, we can.
attention to the posterior capsule. Then the central posterior capsule is flattened,
so the OVD is in the sulcus.
Planar capsule diaphragm.
He does a great deal of polishing of the anterior capsule as well.
Bent bevel up is tangentially approached to the central capsule,
I'm not sure that's
aiming
necessary.
at lifting up a fold and then perforating it. Other than usually taught, OVD is not yet injected through the slit created. Instead, the edge of the capsule slit is grasped with blunt capsule forceps, and the capsular rex is initiated. Only now is OVD injected in order to separate the anterior hyaloid from the posterior capsule.
You can choose
This
your
avoids
technique.
injection of OVD into the vitreous body should a firmly attached hyaloid have been inadvertently punctured together with the posterior capsule. The posterior
He wasn't
capsule
doing
edge
that
is
when I
then
learned from
grasped
him.
by
He must have
forceps,
had one
and the
problem.
capsular rex is completed with 2 or 3 additional passes.
And sometimes a little maneuver at that point, pulling
Using a
backwards or
blunt
centripetally
cannula,
is
Helon
appropriate.
is injected beneath the posterior capsular rex's edge in order to circumferentially visco-dissect the anterior hyaloid from the peripheral posterior capsule. The advancing dissection line can thereby be easily visualized. Now the nasal capsular fornix is reopened and prepared to accommodate the leading IOL loop. The injector tip is inserted through the tunnel with a slip-oriented sideward to exclude tissue trauma to then be rotated clockwise to allow the leading loop to exit horizontally and settle in the reopened nasal fornix. The exposed piston gently pushes on the temporal optic aspect in order to entrap it beneath the posterior rhexis edge, which prevents the edges of the unrolling IOL optic from touching the subincisional endothelium. In this live surgery case, the inferior optic edge happens to slip under the posterior capsular rhexis, which is easily corrected for by simply lifting it up with a spatula. Using a Y spatula to gear the trailing loop, while a blunt spatula is positioned on the anterior optic surface, the trailing loop is also inserted into the capsular fornix while slightly rotating the IOL.
So as you saw, it wasn't that difficult for me to do, and partly because it was a three-piece lens that was much more flexible than
After
this one that he
recentering
used,
the implant,
not
the optic
available
is
in the
entrapped
US.
in the posterior capsular rhexis by gently pushing on the optic periphery 90 degrees away from the IOL axis. After draining some of the OVD by depressing the tunnel bottom, and after hydrating the paracentesis openings, a coaxial I&A probe is inserted and the residual helon aspirated with the aspiration port pointing upwards and to the sides. Finally, the I&A probe is quickly retracted to allow the self-sealing corneal lip to shut down, thus excluding anterior chamber shallowing.
And I usually somewhat hydrate and empty
The optic now
tunnel
centers within
ahead,
the posterior
as
rhexis
Osher showed us.
buttonhole, and the posterior capsule is seen to overlap the optic periphery while its edges undercross the haptic optic junctions.
So I mentioned not to start right away unless you have, I don't know what this is doing. Nothing's happening with the video. I don't know why it's bumping that way, but basically I'm just showing you another. Oh, this is forward capture. So this is a case where I tried his lens, and I actually hadn't made a big enough posterior rhexis, and so the rhexis broke. And I could see it break, and I still had my hyaloid protected. And so all I'm doing is forward capturing this lens through the anterior rhexis. And you'll have a wonderful outcome with a patient who will never need a YAG and no vitreous prolapse. And so this is the rescue technique that I wanted to show in case you were to rupture the posterior capsule. And then I am using tree essence just to be sure that nothing came forward, which it did not, because I knew the capsule was ruptured. Now, I just want to make it clear that it's proven non-inferior, that it has some real advantages, that there's reduced stray light. Every patient that Menapace did in his prospective study who had no capsule preferred it to their 20/20 clear posterior capsule. You know, when we look with the slit lamp, we know there's stray light from that posterior capsule, even without fibrosis and Elschnick's pearls. We want to keep the two-chambered eye with all its known and theoretical advantages. When we rupture the posterior capsule with a YAG, we virtually always rupture the anterior hyaloid, and that gives us floaters. And if there's not total fibrosis of the lens diaphragm, then we're going to have a one-chambered eye and have inflammatory molecules flow backwards and oxygen flow forwards to the trabecular meshwork. And I think that with our increasing numbers of early YAG lasers because of the LAL and because of multifocal implants and so on, we're going to see an increasing number of postoperative problems down the road associated with our diabetic retinopathy, earlier CME, and pressure issues. This will allow a new design. We'll no longer need a square edge on our lenses, which decreases dysphotopsia, and a 90-degree angle would be preferred. I would love to be able to talk to industry, the right people in industry, to consider putting particularly toricity, if not multifocal options, onto a three-piece lens. And the light adjustable lens is the only three-piece lens with a not ideal optic haptic junction and a silicone lens. It is capturable, and could be used today, but it's not necessarily ideal. Also, when we put it in the bag, people are noticing that after YAG, that position changes, and we've already locked in a finding, so we might consider posterior optic capture with the LAL. There's a predictable ELP, although we don't have a perfect nomogram as yet. You must add maybe a half a diopter, maybe one, depending on how high power your lens is. And the economic benefit to society, certainly in the developing world where people may not have access to YAG, but certainly even in every other world where we pay for YAG lasers, I'd like to see Medicare pay more to do it the first time with posterior optic capture and less for YAG laser capsulotomy, but I may be run out of town for even saying so. Now, a quick case, if we still have time, is that okay?
I think we need to have the next speaker also coming.
Okay, to move along. So at any rate, I just want to show you that I did same day bilateral surgery on a brunescent patient, was handicapped, and did capsulotomies as well, posterior capsulotomy and optic capture. And the reason I was going to show this case is just to show it's so controllable that you can actually cut. Oh, well, I guess I've gone too far, but you can actually enlarge your posterior rexus without difficulty. So we don't want to see this as what we consider to be a perfect outcome. We want to see that. Thank you for your attention.
Thank you very much, Dr. Lisa. That was really wonderful, like always. And this technique we did try it here also at the hospital, and the patient is also doing very well. So thank you very much for this talk. Thank you. Thank you.
Thank you.
So over to Dr. Aarti.
Good evening. Hi, Dr. Lisa. It was so nice hearing your talk, and very impressive to know that, we can actually, this is very useful to put it like a, capture of the haptics and the optic being, anterior to posterior to the chamber, the anterior capsule. I just wanted to know that when do you add a plus 0.5 and when do you kind of do it in the relay till 1? Is there a particular, myopic or a hypermetropic shift you plan for a ELP to be perfect?
There is no shift in an ELP. That's the point. So ultimately, when we get a proper nomogram, we're gonna be able to nail what that refraction should be. As far as right now, we don't have a perfect refraction, and nomogram. We really don't know because the posterior capsule is so elastic. When we put a 3-piece lens in the sulcus and we optic capture, we use the bag nomogram, right? We don't use the anterior nomogram. We use the bag, and we don't know with the posterior capsule being so flexible whether we should still be using the bag. So I've found that a half a diopter added, unless we've got a really extreme, low or high value implant, is adequate, and I would go up to 7.5 if it's a higher power lens. And the thing is we have no refractive technology on these lenses at the present time, at least not in the U.S. And therefore, if we're a half a diopter off, that's expected by the patient at the present time. So I hope we'll be able to nail that down in the future. I hope we'll be able to have someone who will give us a technology that has refractive ability that can be placed in the bag, in burger space, anterior captured in a complication, any which way, and then we'll not disappoint patients when we can't use the bag.
Perfect. Good evening. For myself to introduce, I would at the outset thank Dr. Reena Sethi and sir to have involved me in such a coveted set of stalwarts speaking on this platform. Dr. Reena, should we start with Dr. Rajendra Prasad's talk?
Yes.
Dr. Rajendra Prasad, I personally get very impressed by him because he is so innovative and he's a prolific surgeon, cataract and refractive. He is almost 45 years experience. He's the eye center at Basant Kunj. And I would be very, very happy to hear him speak on his topic today.
Hello.
First Sight Center.
Can you hear me? Hello.
Yes, we can. Yes, we can. Please
Can
go
you hear
ahead.
me?
Yes, we can, Dr. Sir.
All right. Okay. Thank you very much.
Yes.
Good evening, everyone. And I thank Arunodaya Desert Eye Hospital and especially Pan Ophthalmologica because I have been a very regular member of Pan Ophthalmologica because I have been attending their conferences for the last many years. And it's very kind of Dr. Sethi and the whole family that giving me this opportunity here also in this beautiful gathering. So today I'm going to talk about IOL placement in challenging PCR cases. So So you know that these intraoperative PCR have a variety of range, like ranging from 0.2% to 14.1%. This is primarily because so much of differences in the incidence. This is primarily because of the systemic factors and orbital factors, ocular characteristics, type of cataract, and especially the more important is the surgeon's experience, which counts much more in creation of the intraoperative PCR. So ocular risk factors include very shallow or deep AC and type of the cataract, especially the PPC, hard brown cataract, intermittent traumatic, pediatric cataract. They are more prone to develop the intraoperative PCR, pseudo exfoliation, small pupil, weak zonules, floppy eyes, floppy bag. So these are the other conditions which increases the incidence of intraocular PCR. High myopia, vitreous degeneration, and vitrectomized eyes. So these are the eyes which we need to take a lot of care to prevent the PCR formation. Media opacity, corneal scar, and vitreous hemorrhage. So all these factors are very important, the ocular factors which can increase the incidence of the intraoperative PCR. And intraoperative risk factors include sudden AC surge, sudden shallowing of the anterior chamber, sudden rise of intravitreal pressure, forward bulge of posterior capsule, pre-existing capsular defect, or inherent weak posterior capsule. So many of these factors also are responsible for the intraoperative PCR. So I'll just take you through some cases. Now, this is the first case where we had an AC surge. As you can see, a sudden AC surge has let the phaco probe hit the posterior capsule. Now, we are still left with few fragments of the nucleus, and we have a good large PCR. So only thing what we can do at this stage is, because this has an edge, this PCR has an edge which could extend during the rest of the procedure. So we need to complete it, this PCR into a PCC. So you can see now I have created a beautiful PCC. And this patient was actually posted for the trifocal IOLs. I'm still going ahead with the trifocal IOL in this particular case. And the important point while injecting, because your leading haptic is very important, because your leading haptic has to be positioned under the anterior capsule so that you hit the fornix while placing it, and then you can place the IOL into the capsular bag. The rest of the pieces can be very easily removed with the phaco emulsification. And you can see, because I'm not using too high parameters here, so keeping it low, and then stain the if at all any vitreous is there, because this luckily this patient did not have any vitreous prolapse or vitreous bulge, so we are completely safe and the IOL is well positioned in the center. So nothing to worry in this particular case, because we had a very good result. So another case you can see here, this inadvertent hit of the phaco probe on the posterior capsule. Now, in this particular case, what you can see is, because while taking the last fragment, the phaco tip has hit the posterior capsule. But luckily, you can see here, there is no vitreous loss. And this PCR is already a sort of PCC, because it's a round circular PCR which has happened. So we don't have to do the any other maneuver. So since there was no vitreous, so I'm straight going ahead with the IOL implantation. Again, a single piece foldable IOL. And as you can see, because the leading haptic, I'm trying to push it into the fornix underneath the anterior capsule. And then you can safely place this IOL into the bag. So the IOL was well placed, and so important point is because while placing the IOL into the bag, you have to be very careful, like you should not extend the PCR, and your haptics has to be well tucked into the cornices so that your IOL placement is well correct in the center of the optics, and get a good result. So this was another simple case where we had a circular PCR. So I'll take you through this third case. So here you can see, because this case had a very thick apinucleus which is almost stuck to the posterior capsule. And while removing the apinucleus, I could see a large linear PCR. And you can also see here again a large radial PCR, which is extending from one pole to the another pole. And this is what you can see here. We tried to see if there is any vitreous, but there wasn't any vitreous. Also, again, in this particular case, I decided again to go ahead with the single piece IOL. But here in this particular case, what is important is you don't inject the IOL directly into the bag, just keep it on the anterior capsule first, and then you can very simply nudge these haptics into the bag, and you can see the PCR, a large PCR. Inject good amount of the viscoelastic after injecting the IOL, and then see the. So what I'm trying to do is trying to hold the first haptic and nudging it into the capsular bag. So it's safely going into the bag, and this is the second haptic. Very simply goes into the bag. So this is how you can place the IOL in this situation also. Although you had a very large PCR, but I could manage this particular case by placing the IOL safely into the capsular bag. So this was another case where you can see a very hard cataract, while phacoemulsification of these fragments, what I could see, because during the phaco something was wrong, I just held it, injected viscoelastic, and then trying to see injecting visco under this nuclear piece. So I could see a large tear here, PCR again, a radial PCR, a large PCR. So what I thought was that the best thing to do in this particular situation was to put an scaffold, IOL scaffold. So I'm just injecting the IOL underneath this large nuclear fragment, and place this IOL very safely without disturbing the PCR, and I could very safely inject this IOL into the bag, directly into the bag itself, because although the PCR was a unidirectional, it was not extending to the pole. So once I could place this IOL, then I'm trying to inject, trying to emulsify the remaining fragment of the nucleus. And as you can see, this was a quite large fragment and very simply emulsified. And you can see the IOL is well placed, and the result was quite satisfactory in this particular case also. So the another case where you can see, because while chopping this large hard nucleus, what happened, I landed up into a large PCR. See, the nucleus almost was trying to sink into the vitreous cavity, but somehow I could hold it, brought it on the anterior capsule. And this is how what I'm trying to do, because now, since the PCR was quite large, so it was not possible to continue with the phacoemulsification. I extended the incisions and then got these fragments out very simply with the help of the visco expression. So you can see then I just did a small one corneoscleral stitch, and went inside, tried to see if any vitreous is there, and I did a anterior vitrectomy and placed this three-piece IOL. Now simple, because since the pupil constricted while injecting the IOL, but I could see that the anterior capsule was well preserved in this particular case. So with again nudging the one of the haptic on the entry capsule, and I'm trying to place this IOL into the sulcus, and then the second haptic, I went into the same direction and dialed it into the on the anterior capsule, and you can see the IOL is well placed and with the satisfactory result in this particular case. But what happens when you have a complete PC loss in many situations, because complete PC loss would happen because you cannot put any kind of IOL, then the general alternatives for the lack of the capsular support, either we can leave the eye aphakic and then plan it for the secondary IOL later on, or we can put an anterior chamber IOL, which is not now these days practice. And the another option is the iris fixated IOL or the scleral fixated IOL. So this particular case, in a scleral fixated IOL, we have a sutured SF-IOL or glued SF-IOL, which we have been practicing very frequently. Sutureless, glueless SF-IOL, that is the Amani's technique. And then very recently introduced new technique is the CMT flax IOL, that is sutureless hydrophilic lens implantation. This is the lens, and which we find very convincing in this situation, and very simple to implant this IOL, and very good results because its stability and its hold is perfect. And I'll just show you how this lens is implanted. So this was the case where we had a complete loss of PC and the nuclear dislocation into the vitreous. We took the help of the retina surgeon to remove this nucleus, and this is how we went inside. The retina surgeon went inside and did a phaco-fragmentation for this, the complete full nucleus which was lying on the retina. This nucleus was completely removed, and so you can see the nuclear pieces are being removed along with the partial vitrectomy. And then this CMT flax IOL was planned for this particular case. The scleral flaps were made, 2 scleral flaps were made, and you can see the implantation is very simple because you just need to hold the leading haptic, pull it out of the sclerotomy, and place it. You don't have to suture, you don't have to anything, because these T haptics, they are actually, you can see the T haptic. So this T haptic is brought out and it's placed and glued. So simple. I'll just show you one more case of this particular IOL. So this was again a case of complete loss of PC, and so this is how you can mark for the positioning of this IOL. This is Dr. Amar Agrawal's marker. Make a scleral flap and then sclerostomy from underneath the flap. This is how you make it, and once you make the sclerotomy, then you start injecting this is the forceps which would hold the leading haptic, and you can see the IOL, and look at the T haptic. That's very simple. It's a T haptic, and this T haptic is held with the forceps. The leading haptic is held, and it is brought out of the sclerotomy. And even a very simply, any anterior segment surgeon can do it very simply, and very simple to implant this particular IOL. And this T is brought out of the sclerotomy, and just placed it the second haptic. So you go through the second sclerotomy and bring it out. This is how you hold this, and you bring it out, pull it out, and
I didn't catch that.
then
Could you try again?
And this is how these haptics are placed out of the sclerotomy, and you can see the haptic. See the haptic here. This is how the haptic would look. The placement of the haptic would look. It's placed vertically, and it's stable, absolutely stable. And then the conjunctiva is brought and glued. This is how you get a result. A very well placed, centrally placed IOL, and you get a perfect and very beautiful result in these cases. So Another option is the this
Dr.
iris
Rajendraprakash, if you can just
fixated
conclude.
IOL. This is the IOL. You can see the IOL, how this IOL is fixed, and this
Can you
is
just conclude,
the
Dr. Rajendra Prasad?
this inclination of this particular IOL. A very simple technique again. This is another option in the complete PC loss. And you see that how you hold the IOL with the IOL holding process. And this process is very important because it gives you the placement area of the IOL and the mark where you have the inclination point. And this is how you can incubate this IOL. And this technique also gives very good result. You have to always do a iridotomy in these cases, and these cases give you very good result. This is another case of
Dr. Rajendra Prasad, if you can conclude, please.
just finished. 30 seconds more. This is how you another iron, and this is a little different technique because you place the iron on the because these ions have a different inclination point, because some of these ions have an inclination point at the center, some had at a one edge of the haptic. This is how you can fix this ion, and you have to take it underneath the iris and then fix it. And as you can see now, this ion. So these are the two very simple technique we all have been practicing in our. So these are certain important points which need to consider while placing these IOLs, the SF IOL and even the iris inclination IOL. And so any intraoperative, to conclude, any intraoperative PCR, your strategy has to be like you need to recognize at a particular point, because if your recognition is okay, then you may not land up into the complication, and then you can very simply manage these cases. And if once you recognize, you just stop for some time, stabilize the eye, and then plan it and then proceed. Your analysis is very important, what IOL and what kind of IOL you are going to put in that particular cases. If you think that any kind of IOL placement is not possible in that stage, you can leave it and do a secondary IOL later on, which would give you much and much better results. Thank you very much.
Thank you so much, Dr. Rajendra Prasad, for covering up all different ways of managing the PCR and giving good results to your patient, good centered IOL, and the various options that we can consider. Thank you so much.
Thank you. Thank you very much.
Our next speaker is Dr. Shail Vasavda. So Dr. Vasavda, I just ask you, request you to stick to time, and he's going to be speaking. Dr.
Can I present Reena? You want?
Okay. So I think you already have your slides here. So go ahead.
Yeah, I'm sorry.
I think you're feeling a little unwell.
Shall I've developed one serious lung infection. I'm very sick. So I just want to finish it off and lie down. Sorry, Shell. Thanks, doctor.
Yeah. No problem. Carry on.
Yeah. So very good evening to one and all of you here in this lovely audience. And thanks, Dr. Reena, Dr. Aditya, Dr. Arun, all of you for giving me this wonderful opportunity to be there. And I felt I had to do it well this time and not let it down. I won't be taking much time. It's going to be a short talk. It's about refractive lens exchange. Now, do we do it? Is it a role in the armamentarium of cataract and refractive surgery? This was an annual report of 2022 of the European Registry, and what that tells us that refractive lens exchange currently dominates the refractive surgery landscape ahead of LVC and phakic IOL, and approximately 80% of refractive surgery cases were reported. Now, that somehow does not fit into our Indian scenario as yet. But then we need to try to understand this in this entirety. What's driving the shift to a lens-based refractive surgery? Now, what we do know that our patients are extremely intelligent, aware and desirous to lead the life in the best, most optimal way, most challenging hobbies. And they know that they can get what they want because that's how the technology is advanced. And it actually doesn't even matter about the dim light or bright light condition. They want to enjoy every moment of it. But we have to also understand that to be on the edge or leading edge in our practice, we know we have gained full success on our surgical techniques. We do know that we have the most intricate diagnostic tools which pick up the minuscule aberrations of the eye. We do know we have eye trace, which even picks up those dysfunctional lens syndrome. We know we have a range of premium IOLs, which is going to promise us visual outcome across a range of vision. But then the most important question is refractive lens exchange versus LVC. Now, what does refractive lens exchange appear to promise? A long-term solution? Probably. Corrects the condition at its source. In other words, it eliminates the future need for a cataract surgery. And if it's not that you're going to do a monovision and you compromise on the binocularity or the stereopsis of the eye by getting a full power for the dominant eye and a higher, leaving a little myopia for the non-dominant eye. And if it's a patient who's had a laser vision correction done, then that's also going to affect his future cataract surgery, the higher order aberrations which are going to be induced, the intraocular lens power calculation has to be stringent, and the choice of the IOL itself has to be given a grave thought. So then the next question is, who are the candidates for a refractive lens exchange? Needless to say, it's the presbyopes who have a normal ocular anatomy and clear lens, but they want a spectacle independence. They are not going to try these presbyopic glasses, they say. But then trickling into that group is those people with high myopes and hyperopes with clear lens, but not the normal ocular anatomy, and who are clearly not good candidates for a corneal refractive surgery or a phakic implantation and want some solution for their problem. So the expectations are high in this entire subset of patients. And this is another study, a large series of immediate sequential bilateral refractive lens exchange cases from UK. There were 28,827 eyes who received multifocal intraocular lens, and it was seen that 86.2% of the eyes had within 0.5 intended refraction. Now, there is no other large study to be comparing about the IOLs in a young RLE group. However, we can always extrapolate the results of the outcomes in a regular cataract surgery patients as things are not going to be any different. But once we have decided to do a refractive lens exchange in a particular subset, it's very, very important that we do a complete evaluation. A dry eye workup has to be done, OCT macula, pathology to be ruled out, eye trace will give its own information, a topography has to be regular, a thorough physical evaluation, and to ensure that there's absolutely no contraindication for using a premium IOL. So the most important thing, we have to nail the biometry. And when I say accurate readings, the K has to be repeated. And if there is an ocular surface disease or a minuscule suspicion, we would have to treat that and then repeat our K values. There is absolutely zero tolerance of compromise in these eyes. We need to use all the advanced generation formula. I use Barrett's, but there are a whole range of good formulas which are available. Whatever the astigmatism has to be corrected. Of course, you can do a mini monovision with EDOF, and not necessarily it has to be a trifocal only in all cases. But I think it's important that we understand the visual needs of our patient, their occupation, lifestyle, everything, and then discuss with them far more than you would discuss with an older patient, because we have to tell them that spectacle independence comes with a price, a loss of contrast, and a possible dysphotopsia with some of these premium lenses. So there is no perfect IOL technology to guide us to that choice. But then if a person wants total spectacle independence, yes, trifocal with a clear understanding of neuroadaptation and all that it comes with it. And otherwise, if he wants fair amount of independence, EDOF seems to be a good choice. In fact, this is again a study way back in 2020-2019 survey, wherein in 2019 there were only 20% for EDOF, whereas in 2020 there is 32. And if we look at a survey of 2025, it's going to give us an entirely different picture, because what people have understood that EDOF does promise a lot more, and it does take away that for dysphotopsia or that contrast sensitivity loss, which is a big challenge with the trifocals. So look at the candidates. Now, hyperope with presbyopia is going to be an ideal candidate for us. And this was one such patient here. They are very easy to satisfy. And they've had a compromised life with poor distant vision and near vision. And they would even tolerate a small residual error. Again, the eye trace, if you have access to it, is going to pick up those internal aberrations, those pupil dynamic changes, those lack of asphericity, and anything less than 5. And the patient which comes to us for a correction is somehow not happy with the quality of vision. And if the DLI tells us that there is a significant loss of quality and the patient could be, the lens is the due cause, it does need more consideration. And of course, this was a patient who had a low astigmatism, and we chose the right IOL power. And if you're on a femtocataract platform, then it becomes so much more easier to deal things like get a typical honeycomb pattern and you're very stable at the chair, there's no ultrasound nose on. That's absolutely challenging. And you've just clipped apart and all those pieces are ready to be gobbled. And in no time, it becomes a very uneventful surgery and you're able to do the best for these eyes. And so maybe a femtocataract platform would be the way to go if you're doing a clear lens exchange. And again, this patient did very well. Now, this is the next segment of patient, a plano presbyo. Now, he is going to be a challenging patient to satisfy because he's had great vision for distance and he assumes and believes, however much you may talk him out, that this is what he wants and this is what we have to give him when he gets a clear lens exchange. So if we are not on a femtocataract platform, these are very soft lenses. So you could do just a flip, just a gentle hydro, not overdo it, and just tumble out the nucleus. You can easily see it at the equator and just nudge it up and eat up the small, carousel it out, and then all you have to do is just strip the cortex and place the intraocular lens in place. Now, the next segment is a low versus high myo. Now, it's a low myo. He's again keen on spectacle independence, and he's going to be a lot more demanding because he's able to remove his glasses and read well. So you need to do a thorough retinal evaluation, rule out any retinal pathology. You're lucky if he has a PVD when you could probably consider that thought. But however, having said that, this patient had all those satisfied points, and we went ahead and did a laser cataract surgery. Now, when not to do is the next important question. This is a 59-year-old patient, female, who works with the computers. And there was a moderate diabetic retinopathy and a MAC10. Now, I would definitely avoid a trifold, and I just would do a toric monofocal for her. Now, again, this is another patient. What we need to understand here is, even if the fundoscopic evaluation tells it's normal, in 13.7% of these eyes, there could be a macular pathology which has not been picked up by a routine fundus examination. And we need to understand all of these interface abnormalities alters the choice of your intraocular lens and your intent for doing a refractive lens exchange. What do we do in the next segment? A refractive lens exchange in a high ametropia in a pre-presbyopic age. Now, this was a high hypro who wanted a correction about +9 and +14. 14 plus 49 was amblyopic. And he had a low ACT. ICL was not possible. And of course, we can't be doing anything on the cornea in this particular patient. The other important thing is it's a small eye. So it could have a normal anterior chamber depth. It could have a shallow anterior chamber depth. And these are large powered IOLs. So even if you have made a small change in mistake in your refractive error biometry, there could be a large refractive surprise. So this was a patient way back, nearly a decade back, who we didn't have the very latest of formula. So these were the two values which came up. And we went ahead and did a surgery. He was plano in one eye. And in the other eye, he had a +6 diopter of residual. And that with the Nichamens nomogram, you multiplied with 1.5, it was +9. And at that time, we did not have the sulcoflex lens. So we placed a hydrophilic because the base lens was hydrophobic. And you choose a large optic and with a posterior concave surface. So there is no interlenticular fibrosis. And now with the sulcoflex lens with a nice indulating haptics, piggy bag lenses, these seem to be a solution for these refractive surprises in these eyes. The next segment is a high myo, a 35-year-old woman. Inadequate AC depth to ICL, -14, -15. So we know we can't do an LVC. She's desperately interested in prelex. But what we need to understand that even if you've done a great cataract surgery, even if the retina looked normal, an RD can present a few months away or 1.5 years away or a few years away. So it becomes very, very necessary to be cognizant of the fact that could be something in macula which could be evolving. There could be a iatrogenic PCR which you could have created. There could be a PCO which you may have to address later in this very young age group. The most important thing is we need to rule out if there is a PVD. That is sort of a little encouraging factor. And with a lot of counseling and with all the things being looked into, we went ahead and did the surgery for this eye. But yes, it has to be an optical biometry and the best of the formula. The last segment is a post-laser vision corrected patient, and differing opinions are there in different annual spotlights. And like, do we do a monovision, mini monovision, monofocal mini monovision, or do we lead off? When would I do a trifocal? Like, the prerequisites are the patient should have tell you that he was very happy after the primary refractive surgery. The ablation bed should be well centered with no irregularity. He should have had no complaints of night vision problem after the primary laser vision correction, a good ocular surface, and a highly motivated patient. And again, within the 3 millimeter optic zone, it should be a regular bow tie. And you should compare astigmatism magnitude in two biometers and understand that there is a consistency in the K values and the astigmatism. And this particular patient opted for pure C and did very well and wanted the same for the other eye. Now, there are other options to be considered. I would do a trifocal for a patient too, if the patient is quite clear and the higher order aberrations are not at all to be much in consideration. But what we need to understand is this refractive lens exchange is a different ballgame. It is not about vision restoration. It's about vision enhancing. So we have to be absolutely accurate in our biometry, IOL choice, the best phaco technique, immediate restoration vision, best of lenses. And we should take up only those patients where you can give him a lifelong guarantee. Choose the right lens and be the safest surgeon and do something this is really very, very right for the patient. Thank you very much for giving me this wonderful opportunity.
Thank you so much, Dr. Chitra, for this beautiful presentation on refractive lens exchange and all the different scenarios, because often we really don't understand where to do this and how important it would be, or what are the shortcomings that the patient is going to be expecting out of the outcomes. So thank you so much for this enlightenment, and get well soon.
Yeah, and all the best for your meetings. Thank you.
Thank you. Thank you. So is Dr. Aarti there? So let me just introduce Dr. Shail Vasavra, who is from Ahmedabad and from Raghudeep Eye Hospital. And he's going to be talking about the cataract surgery crisis management. So over to you, Dr. Shail.
Thank you, ma'am. Thank you, sir. And special thanks to Dr. Aditya and Dr. Vaibhav for this very kind invitation. And congratulations on making it grander and grander every year. So this was a 54-year-old male with a bilateral posterior subcapsular cataract, nothing that we had expected to go wrong during the surgery. And while removing the last fragment, as you can see, I can notice this entire anterior capsular split, and he was planned for a toric IOL. So the first thing that we want to now make sure is that this anterior capsular tear doesn't go around and wrap around towards the posterior capsule. So we inject dispersive viscoelastic to prevent sudden shallowing of the chamber. Then the tricky part to remove the cortex from this area, and for that, as you can notice here, I've reduced my flow rate only to cc. Now, aspiratus attracts the aspin prototype. Therefore, you can see things are happening very, very slowly, but at least this low flow rate, things will control so that capsule or zonules have a chance to reflux them back. Now, in a standard situation, in this situation, it's not a big deal to place a single piece IOL. Just orient the haptics in the direction away from the capsular tear because you have a rest 3/4 of the anterior capsular axis intact. But as luck would have it, we were supposed to place a toric IOL and in the exact same axis of the anterior capsular split. So the first doubt or the first question that we have is, can we place a single piece IOL in an area of open anterior capsule? Because if a single piece haptic optic junction comes up in the sulcus, that can be lethal for uveitis, glaucoma, hyphema syndrome. And second is that even if we are able to achieve that, because this is a toric, will this IOL rotate in the post-operative period and cause more harm than benefit? So after a lot of dilemma and a lot of thought process intraoperatively, we decided to go ahead with the toric IOL implantation. And here, whatever your technique normally may be, here always inject it under cohesive viscoelastic so that you get a lot of chance to unfold the IOL to position the IOL while it's unfolding under viscoelastic. And I'm here seeing the axis placement through my digital marking system in the microscope. And this is roughly where I have to place, right in the area of the anterior capsular split. So I'm making sure that I rotate it almost into the axis. Here, because there is an anterior capsular opening, you don't actually need to go physically behind the IOL to remove the viscoelastic. Just tapping on the IOL while irrigation aspiration will make sure that the viscoelastic comes out from this open area. So here, first of all, we made sure that the IOL is in place at 112 degree, right in the area of the anterior capsular split. And as you'll notice, as I tap on the IOL, the viscoelastic comes out from this open area of the anterior capsule. And even in the end, make sure that the chamber doesn't collapse and the IOL doesn't come forward, or it doesn't rotate. So this is how it looked on table, but the real test of this patient will be in the post-operative period. And the patient did very well 2 months, and now 2 years, more than 2 years post-operatively, the IOL has remained absolutely stable in the area of the anterior capsular rexus behind the rest of the 3/4 anterior capsule. There is some fibrous PCO which has developed on the opposite side, but the visual axis is clear and the patient is very, very happy. So toric IOLs can be considered in selected cases of anterior capsular adhesions where stability is not an issue in the long run. A second case of a 64-year-old female of a grade 3 myop and planned for a flax with a toric IOL, and nothing once again that we expected to go wrong. Now, while doing irrigation aspiration, I started noticing some fluttering here, and I thought maybe this is just dispersive viscoelastic, nothing else. But as more and more cortex is removed, I'm seeing what I dreaded should not be the situation. That is, I have a Descemet's tear here. So as you can notice here, this entire area is a Descemet's tear that has occurred, and the only good part is that I can see something attached at the base. So the good part here, first thing is that I'm able to at least know what has happened. So I've created an iatrogenic Descemet's detachment or a Descemet's tear. It is still very much attached at the base. So I still have some scope of salvaging this situation one way or the other. Now the tricky part is I still have IOL to be implanted in the bag, a toric IOL, as well as viscoelastic removal to be done. So having repositioned the flap at its original position, I am once again injecting the IOL under cohesive viscoelastic and trying to inject it as posterior as much as possible right into the capsular bag, so that it doesn't bruise or none of my second instruments actually come and come close to the corneal Descemet's membrane. Once again, I'm repositioning the Descemet's, realigning it appropriately at its appropriate place. And now the important task of viscoelastic removal. If you can notice here, I've turned my aspiration probe well away from the area of the Descemet's detachment. So whatever flow rate and attraction will occur away from the Descemet's tear, and therefore I won't inadvertently catch the Descemet's membrane. After having done that, first I'm just trying to use fluid to, this is got wrapped and has got stuck at the side port. So I'm just trying to first inject fluid. As you can see, this is the large area of the Descemet's tear. So I'm trying to inject fluid and unroll the flap, which fortunately now it's unrolling quite nicely. And having done that, my plan is to use the principles of Descemet's stripping endothelial keratoplasty or DSEK, which means align it first at the appropriate axis and then inject air below it and try and make a full chamber air as much as possible. And then I ask the patient to lie down, on the OT table for an hour and a half. Then we took her to the room and asked her to sleep flat as much as possible right through the day. So trying to inject the air as much as possible, filling up all the wounds, and we did give her IOP lowering medications and dilating drops. This is the patient on the first post-op day. Half of the air bubble has absorbed as we would expect. There are Descemet's folds because of the manipulations and the Descemet's area. This is the area of the Descemet's tear, but fortunately it looks quite attached. And we confirmed that on anterior segment OCT that although there is corneal edema, the Descemet's flap here has attached very nicely. So there was global corneal edema, about 700 pachy had become. That's because of the manipulations that had occurred. And this is 2 weeks post-op. The cornea is cleared perfectly. Due to the early inflammation, there are a couple of areas of posterior synechia that develop, but that doesn't matter to the patient in the small pupil, and she's doing very well in the long term as well with the toric in appropriate axis. So each and every movement in the eye needs attention, and the probable time that this Descemet's tear occurred was probably my movement with the chopper. I brought it too anterior while trying to chop or remove the fragment, and that grazed it off. Normally nothing happens in most eyes, but some eyes which are vulnerable with thin Descemet's or thin attachments can cause this. Whenever in doubt, ASOCT should be done and have a high index of suspicion, and the treatment options are quite effective. Thank you so much once again for the opportunity and for this wonderful webinar.
Thank you so much, Dr. Shail. That was a wonderful presentation, especially the DM detachment and how you managed it. Thank you so much. Is Dr. Rashmi there? Dr. Rashmi Mittal, are you there?
Yeah.
So I'd like you to take over for the moderation and introduce Dr. George, please.
So, welcome everyone. Welcome to this next session on IOL evolution, mastering accommodation, presbyopia, and aphakic solutions. So, we have some interesting line of speakers here. Our first speaker is Dr. George Alio, and he will be speaking to us on the Lumina, a new accommodative IOL that really accommodates. So, sir, we welcome you all to this. Welcome you to this session for your presentations. Dr. George, are you here? I think he has not joined yet.
I think we have a recorded talk, so the IT can just help us with that. Is Dr. Kathy there? So I think so we did see Dr. Mirna. Dr. Mirna, you're here?
Just a moment. Hi.
Hi. So would you like to take the presentation?
Sure.
Your presentation on choosing the right IOL, how to achieve the best refractive outcome after refractive lens exchange.
Thank you so much. Just a moment to share my files. Well, it was working, by the way, in some troubles. Just a moment, please. Just really sorry for this.
Do you need some help?
Just a moment, because when I tried it, it was ready, and now it's just gone somewhere, so I cannot share my screen. So just
so in the meantime, do we have Dr. George Alio's presentation, please?
Okay, I'll go out and back again.
Rahul, is Dr. Alio's Tanuj, is Dr. Alio's presentation there?
Yes, ma'am, I have that.
Can you just please play it for us,
Yes,
please?
yes. Give me a minute, please.
Are you loaded up now, Dr. Meena?
Okay, can you hear me now, please?
We can hear you and we can see your presentation.
Oh, that's amazing. All right, thanks a lot. Just to... All right, so good evening, everybody. Thanks a lot for this kind invitation to participate in Ophthalmologica 2025. Today, I will give a talk about choosing the right IOL in the private practice settings
how to achieve the best refractive outcome and give to our patient the best refractive outcome. Since my main field of work is lens refractive surgery in one big private clinic in the UK, where we treat the most refractive cases there. So just to start with, last report from ESCRS survey showed that...
Just a second, I think we don't have your slides here. Tanuj?
All right.
Tanuj?
Yes, ma'am.
Ma'am is just playing her, she's just presenting her slides. So if you can just leave Dr. Georges for the next one, please.
Yes, ma'am. I'm gonna start it.
No, don't start it. Dr. Mindan is just presenting her slides. Yeah, good.
Okay, sorry.
Thank you.
Okay, is it okay for me to continue?
Yes, please.
All right, so the last ESCRS survey report showed that premium IOL conversion rate has more than doubled in the last 8 years period, over the last 8 years period. Also, trifocal IOLs remain the most frequent lens of choice. However, popularity of EDOF IOLs has reached and equalized to trifocal IOLs over the last year. It's combined refractive procedure, lens refractive procedure is combined decision involving doctors and their patients, and the most common concern is still price to the patient. So it means that cost of the surgery is still not affordable to majority of our patients. The second and third most concerning problem was that they've been worried about quality of vision issues during the nighttime, or also loss of contrast sensitivity. Nowadays, cataract surgery is becoming refractive lens exchange procedure. And what does it mean? It means that even patients with cataracts who are coming to us to get their vision better, just because of the cataract, they even want to see without glasses. And that's our reality. I put on this slide quotes highlighted from our esteemed doctors, Professor Jorge Alio and Dr. Ribeiro, who highlighted in the recent years importance of including premium IOLs in our practices. So patient satisfaction reflects success in 4 separate areas. So first of all, surgery needs to be uncomplicated. Then we need to think about astigmatism, for every refractive patient. Also, we need to choose the optimal IOL for someone's lifestyle and visual demands. And the last but not the least important is to understand patients' needs, and of course to patients to have reasonable expectations. So factors needing consideration. When patients are coming, refractive patients are coming to my office, first of all, what I think about is about their visual requirements. So I ask them very easy and very straightforward questions. What do you do in your life? What do you need your vision for the most? What is your lifestyle? And how do you correct your vision at the moment? And with these couple of questions, I can get better into their lifestyle. Also, I can understand where they struggle the most with their vision. Also, data about their previous prescriptions or spectacle contact lens wearing habits are very important, which means if someone is wearing glasses only when they drive or when they read, or they like to wear multifocal contact lenses, or even they prefer monovision contact lenses over the multifocal contact lenses, it can give me a lot of information about their visual system, how they are used to function at the moment. And that is also helping me to understand how they could be like accepting new premium IOLs. Also, eye examination findings are very important, as well as all ocular and systemic comorbidities to be considered. Personality, as we all know, perfectionists are not the best candidates. And the last but very like important category of patients are previous laser vision correction patients, because now after like these patients are coming to us with cataracts. Those are people who had laser vision correction maybe 20 years ago. They are highly motivated. However, they have high expectations because they had that, like I would say, very easy procedure. Long time ago, they could see everything after laser vision correction, and they expect very similar with premium IOLs. Also, complex counseling is very important. Always we need to cover serious risks, side effects, complications, advantages, disadvantages of premium IOLs, and we need to be very clear about spectacle independence. So I highlight them always that 90% of them will have like achieve their expectations. 10% of them might need some glasses in some situations, or even would need some enhancement surgery. And of course, 10% of patients could have some quality of vision side effects later. So in preoperative evaluation, apart from general ophthalmology exam, we need to do some like extra tests, extra evaluation. So we check contrast sensitivity, aberrometry, scotopic pupil is very important, angle kappa, TK, then tear field function, because patient with dry eyes could be later the most complex complaining patients. That's why it's very important to address it in advance. Also, we need to do OCT scans just to see if everything is okay, if there is any pathology behind. And also very important to do visual fields, because sometimes even some kind of optical neuropathy could just be like sneaking behind, and later patient could complain that their vision is worse because of lens that they got. Also, corneal tomography and analysis of both front and back corneal surface is very important. And we need to be aware, refractive lens exchange is not without the risks. So we treat younger people who are more prone to get PCO. That requires even higher rates of YAG laser capsulotomy, which is increasing the risk of retinal detachment. In our clinic, we send every patient who has axial length more than 26 or more millimeters to have our opinion with retina consultants, just to double check their retina and just to have that proof that everything is fine with their eyes, and that they've been explained what could happen later as a complication. Also, here is one of our papers published in 2023, where we analyzed more than 17,000 eyes, and in these 1,700 eyes, and in these results show that in the first postoperative month, we had one unilateral retinal detachment at day 1 and one retinal tear at day 22. So patients are informed more than ever because they all use like technology. And here is, I just put the definition of premium IOL when you put it in Google or another like internet search, because it's telling that it's like visual recovery, giving visual recovery at all 3 distances without complications or visual compromises. And it's something that is really, I would say, high level to achieve. So, but still, nowadays in refractive surgery, we have absolutely better biometry. IOL Master 700, which is great to analyze and give us very accurate biometry, 4th-generation formulas, even artificial intelligence formulas, and ESCRS and ASCRS online calculators. I just put here the lenses which I'm using for those patients. So it's just the classification that we all know. And at the moment, more than 100 types of premium IOLs are available on the market. And multifocal lenses, which could be refractive, diffractive, or hybrid, which are combination of different technologies. Also, I put here one very, I would say, latest classification for EDOF lenses from Professor Alio, where was just like EDOF lenses according to their visual performances and optic features are classified as a pure EDOF, then refractive diffractive, hybrid, which are combination of multifocal and EDOF lens, then lenses with modified central optic profile and lenses with pinhole effect. So nowadays we have more choices than ever. So some patients are suitable for monofocal lenses only with monovision. For instance, people with amblyopia or with stereo vision issues. Multifocal lenses could be used if someone is happy to accept compromises which are coming with multifocal lenses. Very promising and excellent lenses, EDOF lenses, which we also use in our clinics with mini monovision, where we use in non-dominant eye minus 0.75 on Barrett target, and on dominant eye we use 0 to first plus. Also, we are using mix and match, and we mix EDOF and diffractive multifocal lenses. EDOF is going on dominant eye, diffractive multifocal on non-dominant eye. That way, the patients are getting the best of both worlds. They are getting great sharpness of their vision for distance, less side effects, less halos and glare, but still acceptable and better reading that only with EDOF. So that multifocal lens is giving even better reading than with EDOF lenses, and we are in process of publishing that paper as well. Something that is very new and very promising, accommodating IOLs. I don't have any experience with these lenses, but I'm just happy to hear what's next about them. And candidates. The best candidates are people who are highly motivated, not to wear glasses, positive and easy personalities. Then they are happy to accept some compromise. They don't mind wearing very small prescription reading glasses if they need sometimes. Then mild to higher hyperops or moderate to higher myopes are very, very happy after refractive lens exchange. Not so good candidates, people who are very critical and have unrealistic expectations, perfectionists, especially mild myopes, because they are just used to read without glasses. They take their glasses off, they read perfectly. Emmetropic presbyopes, sometimes they are disappointed with quality of vision for their distance, and they have problems with brain adjustment and neuroadaptation. Also, people who are professional drivers, they are not definitely candidates for diffractive optics. Then people who need good vision in night or dark conditions. And of course, people who are demanding for perfect vision at all three distances. For instance, if someone is working in in front of multiple screens, that could be really impossible to satisfy that demand. Also, contraindications for refractive lens exchange and presbyopia correcting IOLs. Even 10 years ago, laser vision correction was still an absolute contraindication for any kind of premium IOL. Now we all use like premium IOLs in those people's eyes, and it's totally like I would say, if we follow all the steps just to do great assessment, then it will not be a problem, and they could end up very, very happy with refractive lens exchange. The most important contraindications, so dry eyes, the most common reason for someone not to be satisfied after surgery, so we need to address it in advance. Iris atrophic changes, weak zonules, discrete dry AMD, diabetes with ocular manifestation, we need to consent patient very, very in details, just to make them aware what is happening to their eyes, and it could progress in the future. Absolute contraindications, we all know them, so I will not just highlight anything. So most common causes of dissatisfaction: refractive surprise. It's so uncommon, but still it's possible. So it needs to be treated after a couple of months when refraction is stable, with some kind of like or LVC or some kind of like a piggy add-on IOL, piggyback IOL, or just to follow up to see what's going on. Then dry eyes, the most common like reason for someone not to be happy with their multifocal lenses or any kind of premium IOLs, because it can also be connected to neuropathic pain, discomfort all the time, which is making patient very anxious, and they just cannot focus on good things with their surgery. Then quality of vision issues, dysphotopsia, PCO. It's very important with premium IOLs to clean the capsula perfectly, and still, if tiny amount of PCO occurs, we need to follow it up and to see if it's problem which is causing the patient problems with their quality of vision, that PCO, or is it something different, like neuroadaptation? So definitely the biggest problem after the surgery, what we noticed and what we noted is problems with dysphotopsia. So hopefully with
Can you just conclude, Dr. Mehna?
Yes, and hopefully with EDOF lenses and with newer technology, we would try to find perfect lens and use it. So in conclusion, strong patients selection criteria are very important. Assessment of associated pathologies, then to validate measures with more than one instrument just to double check. Evaluate degree of functional vision. We use DEL questionnaire. It's very easy for patient to just to get the feedback what they are happy with or not happy with in their daily routine with their eyes, and discuss real life aspects of functional vision. So the best IOL in the end is the one which improves patients' quality of life. Thank you so much for your kind invitation.
Thank you so much for a very elaborate discussion on different types of modalities. Thank you very much, Dr. Mehna. Thank you.
Thank you.
So over to Dr. Rashmi.
Thank you, Dr. Myrna, for the wonderful presentation. Next, I would like to invite Dr. Alio for his presentation. Dr. Alio is the professor and chairman of Ophthalmology, University Miguel Hernandez, Alicante, Spain. He's the founder of Visum Mirandes in Spain and the Alio Foundation for the Prevention of Blindness. His main research area interests include lens, refractive, and corneal surgery. Sir is a pioneer in area of multifocal, accommodative, and toric IOLs, excimer laser refractive surgery, phakic IOLs, and more recently, corneal regeneration surgeries. author of over 835 peer-reviewed papers in index journals, 444 chapters, 98 books, and over 2,876 communications in international congress. He's the chair of Academia Ophthalmologica Internationalis, chair of European Academy of Ophthalmologists, president of the ISRS AO 2006 to 2008, member of the American Ophthalmological Society. He has been the member of the board of the European Society of Cataract and Refractive Surgeries and has received over 103 international and national awards. He is the creator and director of the online international specialization course in refractive cornea and lens surgery. Fellows from all over the world come to his research facilities to be trained under his supervision. We welcome, sir. Over to Dr. Alio for his presentation. I think we have a recorded talk from him.
Yes, ma'am, I have the recorded video. I'll start sharing in just a minute.
We welcome Dr. Tityal also.
Is my screen visible, ma'am?
Yes.
So, yes.
Hello, it's Jorge Alio. I want to thank the leadership of Ophthalmologica 2025 World Sight Day for this kind invitation. And the topic I'm going to cover is whether accommodative intraocular lenses are feasible, and to introduce you to the Lumina accommodative intraocular lens from Apolens. I am the medical director of this project since 10 years ago. The first question is, can we restore accommodation with an accommodative lens? And the issue is not clear because the failures of the past have demonstrated that the theory of bone health, which is the one that is today more approved and admitted, is that the crystalline lens changes the curvature and its power according to the distance related to ciliary body action. This ciliary body action is essential to change the power of the eye, changing the power of the lens, and getting in distance an adequate focus. There are three ways in which we can approach a accommodative IOL. First is with the change in axial position, or change in the shape of curvature, and the change in the refractive index or power. And this is the last one that I'm going to approach with this presentation and the Lumina lens introduction.
There's no volume. There's no sound.
Ma'am, I don't know. There's a lag in the video, I think.
Which are the conditions for a new accommodative lens as far as the failures of the past? First, the question to solve is whether this should be inside or outside the bag. Then the studies have to be performed with adequate optometrical standards and measuring subjective and objective accommodation and in long-term observation, just to guarantee that this accommodation is not for a few days or few months, but forever. Casual bag has been demonstrated not to be an adequate place for an accommodative lens. The reason is that this is a basal membrane of the lens epithelium that once that becomes empty, it loses any anatomical functional value, and as a consequence develop fibrosis and atrophy, and loses the elasticity. This was demonstrated and published by us in 2005 in this paper. We did an experimental animal model in the old monkey, which we implanted a device in order to measure the forces generated at the sulcus and at the claustral bag with a measuring device that I will show to you now. This is the measuring device that was stimulated by this acting the ciliary body, either by the direct stimulation of the Baker-Westphal nucleus or by pilocarpine. In either way, we could demonstrate that after 6 months, nothing implanted in the claustral bag was moving, while in the ciliary sulcus, it was up to 5 years still active. So with this study that is referred in this slide, we saw that the claustral bag is a wrong location accommodative lens and the adequate place to place this lens in the sulcus level. And this is how this lens was developed. This is a dual optic lens in which two varifocal surfaces sliding one into the other change continuously the power of the eye. And you have here the image of the luminal lens, which has a particular design of the haptics in order to be in the ciliary sulcus, embracing the ciliary body, getting all the forces that are generated by its contraction. This is the lens and how it moves. In the animation, you can see how the lens can be moved according to the ciliary body action, and how this is done thanks to the interaction of the haptics with the ciliary body, and as a consequence, the power of the lens changes continuously in terms of the distance. That is, real accommodation changing power of the eye related to ciliary body action. This is a consequence of this action in the sulcus, and this action of the sulcus is independent from the capsular bag elasticity. We have three studies in which we have been first investigating in partially sighted eyes the safety of the procedure, and then the procedure itself was implanted and the lens in sighted eyes in order to start the accommodation in a phase 2 and phase 3 study. I'm going to show to you the results that have been reported from the phase 3 study, performed all of it in Alicante, and this is the international inscription registration of this clinical trial. First, let me show to you how the lens is working. The lens is implanted in the horizontal meridian as far as the measurement has to be precise in order to customize the lens to this meridian. In about 5 millimeters, the other cast is in the result of the lens, and then the lens is empty. When that is empty, we get the lens. Here you have how is the design of the lens with two optics, with two varifocal surfaces that will slide one onto the other. The lens is implanted through an injector that is similar to the ones that we use in regular implantation surgery, and is implanted through the 2.5 millimeter incision, putting this injector either in monomanual or bimanual fashion. In either way, the lens is introduced in the third chamber, as you will see immediately, and directed towards the sulcus. In order to accomplish this, we use cohesive viscoelastic that collapses the anterior capsule onto the posterior. In doing that, we are now implanting the distal haptic in the sulcus, while the trial haptic is going to the sulcus as well, without a maneuver that we do with our second hand instrument, making in one shot the lens behind the iris, and taking care not to be engaged by the capsular bag anterior capsular ring. Now the lens is implanted and the surgery is finished. Viscoelastic is removed and the patient is discharged.
Ma'am, I think there is no audio at some parts of the video.
I think that's fine. We just got a gist of it. Thank you so much.
Ma'am, there is some part of video left.
हाँ तो इसको थोड़ा fast forward करके देखो. Maybe we can see something better.
Of 60. A demonstration that according to distance we have accommodation. You have here in the left And in the right, two samples in which we have a normal person of 66 years implanted with a luminal lens and a 35 years old person with crystalline lens and their accommodation. As you see, we are gaining power according to distance, not as much as the normal 35 to 36 years old person, but almost that. In other words, this is real accommodation, this is physiological, focusing according to distance. The results of Alicante have been very promising because we have most of the patients with a very good vision so far, and uncorrected vision was in about 82% of the cases. It's very good, depending, while in 100% of the cases we had the patients with distance correction, with distance correction without vision that was superior to 0.8. The near vision has been accomplished as well to similar level. Here you see how we have about 100% of the patients with vision reporting 7/10 in terms of patient satisfaction, and how the patients are able to perform normal activities for near without glasses. This is the example that we have in the analysis of our cases. As a consequence that this is a monofocal lens that is focused on different distances, we have no changes in the conjunctive function and no problems in terms of dysphotopsia, hallus, or glare. This is a monofocal lens in different distances, changing the focus depending on the power related to the cerebral body action. As a consequence, that is a physiological accommodation, a physiological function that is recovered. We have some variability of the results, and you should expect in different cases to have different focus scores. As you see here, we have from very good intermediate vision to very good intermediate and near vision. In the bottom line, you have the monofocal lens as a comparison that you see in every single case. We have better the focus score than a monofocal lens. As a consequence, 75% of the eyes had a focus of about 2.5 to 3 diopters. That means 20/40 with Longbar in near vision analysis at 40 centimeters. You have here the clinical outcomes that happen to be the same at 12 months and 24 months. So the accommodation is kept over time. And this is the paper in which you can see and you can read the outcomes of these phase 3 studies published in Journal of Refractive Surgery last year. We have analyzed the quality of retinal image uptake with this lens, which is a very important issue as far as the quality of vision is related to the quality of retinal image. In this paper, we describe a method to analyze in vivo the capability of the optical system of the eye to get an adequate retinal image. You have here displayed the different retinal images that are offered by different lenses, multifocal and EDOF. As you can see, some of the lenses, EDOF, do not provide an adequate retinal image, while others do quite well, but never as a monofocal lens. Same happens with the multifocal lenses. Here you have how behaves the lumina. As you see, compared with the monofocal, it has the same standards of quality in terms of quality of retinal image, which is outstanding. In summary, accommodating lens based on these two varifocal surfaces sliding one onto the other was the fundamental of Alvarez principle, who received the Nobel Prize in 1953. We have a non-compromised quality of vision in distance because we have a very good quality of retinal image. We can accomplish an accommodating range up to 3.5 diopters, and we have demonstrated a long-term stability in the accommodation that is accomplished. We have an optimal quality of retinal image, as we have demonstrated, and the material that we use is a standard one, is hydrophilic acrylic, and with a CE certified medical product. Part of this presentation, all the fundamentals of this lens can be read in our next edition, what will be available in December of this very year, about multifocal intraocular lenses and premium lenses that are under practice, that is published by Springer. I want to invite you to join this university course, University Certified, with 300 hours of teaching activities online and multimedia in English, in which we teach everything about refractive, cornea, cataract, and intraocular lens surgery, with several lessons devoted to accommodation and accommodating lenses as well. And don't forget that in ARIC 2025, which is our online open access Congress, that happens to be available for all of you with the latest news and total update on these topics, refractive, cornea, cataract, and intraocular lens surgery, available to all of you online and open access. And I thank you very much from Alicante for the very kind attention. And I thanks again Pan Ophthalmologica 2025 Website Day for this kind invitation. Thank you very much.
Thank you very much, Dr. George Alio. That was a wonderful, innovative talk. So now our next speaker is Dr. Jeevan Tityal, and I'd like to invite him over. His talk later on, Rise Take Real 2020.
I think my topic was different, you know.
Okay, so you can
Let me-
introduce your topic.
I have, because I had to talk on a, phaco and vericize eye with complicated cataract.
Perfect. Yes, yes.
Yeah.
That's
I'll
right.
just take that, presentation through.
Sure.
I'll share my slide. I hope it's visible to you. Hello?
Yes, it's absolutely visible and clear.
Yeah, thank you so much, Dr. Reena Sethi and Dr. Arun Sethi, for giving me this opportunity to be a part of this very, very exciting, informative international program on Ophthalmologica, and that too in a World Sight Day. I'm going to talk about performing phacoemulsification in a complicated cataract, which was post-Vericise phakic IOL. I have no financial disclosure to be made for this particular presentation. Let me briefly talk about the case summary. This young lady presented to me with a complicated cataract in her left eye, and she had underwent phakic IOL that was Vericise in both the eyes 18 years ago for high myopia. She did very well in between, but there was a history of multiple attempts of re-inclination of the iris claws in the left eye. And if you see the diagram here, you can see there is a large area of stem cell deficiency with one suture mark and vascularization in the superior area. And you can see a lot of iris atrophy at the area of iris claw, both proximal and distal part of iris claws of this Vericise IOL. And there was a lot of posterior synechiae bound on pupil with ectopin UV seen in this particular case. The patient was planned for a phacoemulsification. The posterior segment evaluation was unremarkable, though there was a macular atrophic area, which is myopic atrophy, no as such neovascularization there. The endothelial cell count was quite significantly better in this case, no dropouts. If you see the cornea in our OCT picture was quite healthy. The distance from cornea to lens was almost 3 millimeter in the central area. At that particular time, this was almost 2006 when surgery was implanted. We would have had option of either the ICL for this high myopic patient or a Vericise phakic IOLs, which we know is a rigid IOL of 5.5 millimeter optic size, and the rigidity would require a large incision. The surgical plan for these cases with cataract, first we have to explant this Vericise IOL, then perform the phacoemulsification and implantation of IOL. As far as calculation of IOL power is concerned, it is not much a difficulty in these cases because these phakic IOLs do not change the axial length measurement, and cornea remains healthy because we have not touched the cornea in these cases. Therefore, the IOL power calculation is simple as per the high myopia for these cases. Let's go through the surgery, how it went. So this is the patient you can see superiorly. Because there's a large area of stem cell deficiency, so I can't reopen this area and make a large 5.5 millimeter incision to explant this. Therefore, the only option for us to do a single incision approach for this IOL. Therefore, I'll be doing temporal surgery for this patient with 2.2 millimeter phaco incision, and plan is to just disincubate one particular iris claw, that is the proximal part, and shift this IOL inferiorly so that we can do a procedure without this lens touching the endothelium. So that is the main concern. You can see the IOCT microscope gives you a definitive space of this phakic IOL from the corneal endothelium. The plan was very simple. Let's start with the 2.2 incision, which is from temporal size, which is as such. And you got this one pupil, elevating iris claw proximal, shift this lens inferiorly. Now it is disc inclinate. And this is what I'm going to show. This is the iris hooks, because it's a bound on pupil to have the size of pupil which gives access for a routine phacoemulsification in this high myopic patient. I'm going to put 6 iris hooks because the expanded devices may not work in these cases where you have such a large area of atropic area of iris with bound on pupil. These 6 iris hooks, you can see all the incisions are little posterior to limbus. That's why you can see bleeding from those areas. This is done in view that if you put these iris hooks, there won't be any tenting in the pupil area. Once you don't have a tenting, there are less chances of damaging the iris sphincter, especially in this case. And 6 hooks will give you a absolutely hexagonal space of making a good phacoemulsification. And you can see 2 hooks are very important. One is at 9 o'clock and one at 3 o'clock. So that this is the area from where I'm going to do phaco. So this is going to give a larger space for both chopping and putting the instrumentation through. So let's see, we will put one by one all the hooks inside, then retract the pupil slowly one by one and titrate the area of visibility. Staining the anterior capsule is paramount important to have a good visibility. You can see I'm doing a needle system assisted capsulorhexis underneath the phakic IOL. There is a viscoelastic cover both superior to a phakic IOL as well as the anterior chamber to maintain the strength in the anterior capsule in this high myopic patient and complete the rhexis, which is around 5 millimeter. Do a hydro procedure. Make sure you do a good this is what I'm injecting the dispersive viscoelastic first. Make the little bit of soft shell technique underneath the phakic IOL. Inject viscoelastic over the phakic IOL also, so that it maintains its space both the side below and above the phakic IOL. I'm shifting the phakic IOL towards little inferiorly so that I have a space. You can see at this stage the routine phaco is being done. It is very important to make your phaco parameters as per the high myopic patient. If you see my intraocular pressure, IOP is around 30 in this case, moderate aspiration and moderate flow rate, so that we don't have too much of fluctuation in this particular case in antechamber, which is bound to happen in a high myopic patient. And this is a relatively softer cataract. Therefore, I'm not going to use a longitudinal phaco, only torsional phaco will be used, that to a mild phaco in this case also. So making an initial little chop and trying to divide. Now I have achieved the first division of nucleus. I take out the nucleus one by one, pull it towards the center, leave the epinucleus cushion there till the end, which is going to safeguard the posterior capsule in this particular case. You can see this is one nucleus is being taken off, and you can see my torsional power is very, very little, and CD is hardly 2 at this stage when the half the nucleus has been taken out. And just see in the IOCT microscope, I'll show that posterior capsule is intact. You can see and see the distance here. The distance of phakic IOL from the corneal endothelium is significantly better. Despite disinclination of proximal claw and shifting the lens inferiorly, the distance remained quite safe. So it's not touching the endothelium. In fact, it is protecting the endothelium during our phaco procedure also. This is the hybrid technique of aspiration of a cortex and epicortex. This is a phaco handpiece inside only. I have detached my aspiration tubing and attached to a bimanual aspirator without compromising the anterior chamber dynamics. So this is very important in a difficult cases like high myopic patient. So I'm trying to take out the epicortex at this stage, which is done gently from either side, maintaining the anterior chamber of phaco. Sometimes if you require a phaco also, you can run phaco at this time also, especially if your epinucleus is thick. or some cortical chunk is there, you don't have to restart the phaco and go inside also. So this is the advantage of a hybrid technique. Now this is lens is still inside. The entire capsule has been cleaned, posterior capsule. Now I'm injecting the expand series of multi-piece IOL inside the bag, being a high myopic patient under the viscoelastic cover. The incision at this time is around 2.8, so that my entire nozzle of the injector inside, so that I can open my haptics in the bag. So this, I rotate my hand towards the right hand side so that my haptic open, then rotate towards the left hand side. The lens gets parallel to the iris surface. Now at this stage, with the Sinskey hook or a dialer, you can just simply dial the lens inside the capsular bag. So this, again, you can see in the IOCD microscope. During this procedure also, the lens which was above the iris plane did not touch the endothelium at any time. So this is a safety which we have been doing. Once we center, we'll take out the iris hooks. This has to be done when the viscoelastic is still inside. So and now I have to disinclude the distal part of the haptic. Again, inject some cohesive viscoelastic inside to maintain the space. Hold it and just take it out after disincluding the distal part. So at this time, I've enlarged the incision to 5.5 here. It gently comes out. Put sutures to maintain the integrity of this incision temporal side. Now aspirate the viscoelastic from underneath the IOL and over the iris also. You can see I could maintain the entire pupil nicely in this patient despite having the large area of synechia, and the pupil looks quite okay at this stage. I have removed the suture which was there superiorly for previous surgery, and that also could have been done. And now you can see the entire aspiration is very simple. AC is well maintained, and hydration, injecting the intracameral viscoelastic is done in this particular case. So what we have achieved this patient is a single incision surgery for both completion of phacoemulsification, implantation of multi-piece expand series IOL, and then explantation of the Verisize IOL towards end. I think if you look into this particular presentation of this video, we understand the ocular surface analysis should be done. This patient had a large area of stem cell deficiency because of multiple surgical attempts on superior side. Patient decision making important in these patients because they have to understand the difficulty of doing a combined procedure of explantation as well as the re-implantation of IOL after phaco in these cases. Tomography, the specular count is very important apart from the counseling these patients also. Surgical technique, classically, if you would have not had any stem cell deficiency, we would have gone superiorly first, taken out the phakic IOL simply, put two sutures superiorly, then shift to temporal side to do phaco in these cases also. But now with this technique, I think we need not disturb the superior side. You can easily do from a single port incision and just shift the IOL little inferiorly after disinclubating the proximal part of the iris claw in these cases, which you saw in this video so clearly, and it can be done without actually hampering or damaging the endothelium, which may be the little thought that this iris may be little floppy and the pupil might move, and the IOL also might move during the phacoemulsification. But you saw that it was very, very effectively managed. The other important aspect was these iris hooks also will maintain the iris and pupillary tissue in a one single plane, would not allow fluctuation to happen, and that also will safeguard the fluctuation in the anterior chamber. Post-operatively, all these high myopia patients should be assessed for posterior segment thoroughly. If needed, treatment can be given for myopic CNBM if they have. Detachment is a possibility. Peripheral screening is very important for these patients, and regular follow-up till the very, very long time is very important for all myopic patients. More so for these patients high myopia where they have undergone multiple surgeries, they are at high risk for posterior segment complications. I would like to end this presentation. Thank you for your kind invitations. And I hope that, this entire Pan Ophthalmologica is going to be fruitful to all of us.
Thank you so much, Dr. Dityal. What a wonderful way of handling a situation. I think you put it so scientific because have situations one doesn't know what to do, whether to large take a lens or do it the other way around. And I think you did always your feet would touch the epithelium and you made, and also the space issues. So I think it was so beautifully done with shifting the lens towards one side and then doing the surgery. Very good. Excellent.
Thank you so much,
Thank you.
Sarina.
Thank you. Thank you. Over to Dr. Ashwin.
So next, I would like to invite Dr. Omid Kermani for his talk on new and contemporary ACIOLs for aphakia. Welcome you, sir, to this session, Dr. Omid.
Hello, thank you very much for the kind invitation and very nice talk, Professor Dityal. I liked it. Thank you for that. And I presented a video as I was asked for it, a 6-minute video, and thereafter we can discuss if you like. I think I have to go here. Can you see the video?
Yes, we can see.
Yes, we can.
Okay. I hope you can hear the sound as well.
Not yet. There's no sound yet.
Ah, sorry. You have no sound?
No sound.
No sound. Okay, let me check this. Let's try it again. Better now?
We can't hear.
Yes.
Sir, please stop the screen share and restart with again the same settings.
Know why it doesn't work with the sound. I can hear the sound actually. Can you hear me now?
We can hear you.
Okay, so let me try it again.
So it says you need to cancel your screen share and then reselect it with the audio.
Still no sound?
We could hear something in the background, but perhaps it's from your end, not the video.
From my monitor, I would bring it into the presentation modus. I have the same view as the
presentation, and I could just talk you through the presentation. I don't know.
Yeah,
how
that'll be good if you can just speak.
sound. Yeah, maybe that's a better way to do it. So, but you can hear me now.
We can hear you.
Oh, can you hear me?
Yes, we can.
Hello,
No. I tried again with the video because
Hello, my name is Omid Kemani and I am an ophthalmologist. Could you hear
That's
the sound?
good. Yes, we can.
Okay, in Germany. The video demonstrates cases that I have addressed with a novel custom-made anterior chamber lens. A 24-year-old.
Are there any sound in your video, sir?
It's good now.
Yeah. I had surgery for a unilateral congenital cataract at age 1, resulting in an aphakia. She has worn an aphakic contact lens since childhood. Her visual acuity is best corrected 2025.
Sir, may I help you, sir?
In 2020 in the left eye, with an endothelial cell count.
Hello?
Tanuj is good. It's good.
Yes, ma'am.
It's good.
Capsule back remnants prevent access to the ciliary sulcus for scleral fixated IOL.
Yeah, may I help Dr. Omid?
Yeah, what is the problem? I don't
Yeah,
understand.
sir,
We can
stop share.
Tanuj, we can hear at the moment.
Sorry?
We can hear.
Okay. Okay, play, sir.
Limited options exist in treating aphakia. The FDA-approved Kalman multiflex anterior chamber lens from 1980 is still remaining the primary IOL. While concerns exist about anterior chamber lenses, off-label alternatives like the retroiridial fixed Verisize lens have emerged. Various transscleral fixation methods for PCL and the sulcus have also been developed. Despite these options, none were convincing, so I recommended the patient return in a year while I began exploring solutions. Olaf Morcher, CEO of Morcher Company in Germany, a company with 70 years of eye surgery expertise, approved the proposal that I made. The new anterior chamber lens is made of proven hydrophilic acrylate, measures 12 to 14 millimeter in overall diameter based on the patient's white-to-white measurement, and features a 5 millimeter spherical optic. It has 3 haptics arranged symmetrically as a tristellion angle to ensure smooth, aqueous humor flow without requiring iridectomy. In the following, I will show you the implantation of the Morcher Type 37F anterior chamber lens. The procedure is done under topical anesthesia with a constricted pupil. The anterior chamber is prepped with Viscoat as an OVD, and the plus 16 diopter ACIOL is inserted through a 2.5 millimeter perilimbal incision. Correct insertion is confirmed by the clockwise orientation of the spiral-shaped haptics to prevent pupillary block. After bimanual OVD aspiration, the IOL is adjusted and the incisions are sealed to complete the procedure, which lasts just 2 minutes. Post-surgery, a week-long course of combined steroid antibiotic eye drops is recommended. The post-operative recovery proceeded without any complications. I'm presenting the endothelial images taken before the operation, 6 and 12 months later. It's evident that the new IOL is well tolerated. Uncorrected visual acuity had significantly improved, and the patient did not lose lines in best corrected visual acuity. The IOP remained normal, and there were no signs of inflammation. I have mainly used the new ACIOL for elderly patients experiencing late IOL in the back dislocation, a growing concern. While it's possible to refix or replace the dislocated lens, these procedures are technically challenging and time-consuming. Moreover, there's the risk of surgical trauma and post-operative complications. Therefore, when considering safety, the short expected wearing time of an ACIOL in this patient group is a key factor. Ultimately, If needed, the ACIOL can be easily replaced. In an emergency case, the new ACIOL served as a rescue lens when the heart lens nucleus collapsed during phacoemulsification, preventing the insertion of a PCL. The patient, in poor general health and on anticoagulation therapy, presented a high-risk profile. To avoid prolonged surgery on such a patient, a week after the incomplete cataract surgery, a pars plana vitrectomy with endophaco and an ACIOL implantation was performed. And the surgery performed under topical anesthesia offers patient comfort. The hydrophilic acrylate ACIOL implants are customized for size fitting and aim to be astigmatism neutral at 2.5 millimeter perilimbal incision. This atraumatic procedure does not require iridectomy. Patients recover quickly post-surgery with monitoring through slit lamp examination and endothelial cell count measurements. Thank you for your interest, and I invite you to contribute to the ongoing development and establishment of this promising new IOL. So I come back to the Zoom. Here I am. Can you hear me?
Yes, we can.
I can hear you.
Very good presentation, Dr. Kimani, and
Thank you.
a different kind of design in the lens, which seems like it is good because it can be folded and it can be put inside, and I think quite a promising result. But what about the IOP rise or anything like that that you observe with the lens? Any case of
Yes. I have to say that this lens is not approved yet. The reason why I was allowed to implant it is a pathway of the medical device regulation in Europe, which has been implemented a few years ago. It's very similar to the FDA, so you need an approval to come up with a medical device. Just during the time of development of this lens, the MDR took place in Europe. It's a novel system, so we were a little bit late. If you would have been 2 years earlier or 3 years earlier, the lens would have a CE mark and you could purchase it anyway, and we could do studies. But because of the MDRs there, and this is a niche product, which is not, at least for a company in Germany, it's not so interesting in commercial terms. We did not go for approval. I mean, a company like Marshall with more than 2,000 products, the first thing they have to do is to approve their best sellers in order to survive with the MDR. So that is the problem that we have. We have a problem. We have a lens that is quite interesting and promising for the entire world, I think, especially the global south, but we have no approval. And the way I did it was through the custom medical device regulation, which is a pathway when you prescribe the lens for a single patient and send the recipe to the manufacturer, and then they produce the lens. So that's the way it works in Europe. But then the production time usually takes 4 to 6 months. That's the only way that is allowed to purchase this lens in Europe. And when I have a patient who needs such a lens, I order a lens, a standby lens, and 2 more lenses for each eye, 1 lens with this lens. So I get 4 lenses for 1 patient. I implant one and put the other ones in stock in case I have other patients who need it. In total, the number of patients in my office is limited. I have maybe 20 patients a year where I need this lens, but it's helpful to have it, you know. And then that's the reason why I think it's a very helpful device. I just imagine you're doing a full day cataract program with 20 cataract surgeries. You have a complication at case number 5, and you want to do now. What are you going to do? You are in stress. The patient is in stress. The whole team is in stress. The surgical time prolongs to an hour or so, and all the other patients still need to be done. If you have a rescue lens, you can put the lens in the patient is not aphakic the next day, and you have still time to reconsider the whole procedure and maybe do a sulcus lens later on. But you have a rescue lens, and I think this is really something we can need. And so I'm continuing. I'm not allowed to do studies. I'm in private practice. I'm not a university hospital. Mr. Morcher was open for the development of this lens, but he said our financial resources are limited in coming up with a controlled study. It costs a lot of money. We cannot do it, but we provide you with the lens, and it's a nice idea, and that's the situation we have now.
Thank you so much. Thank you, and all the best for the future of this lens, and I'm sure we'll get it soon here as well. Thank you.
Yeah, so you're cordially invited. You know, this lens is freedom to operate. It has no patent. Whatever is received in let's say remuneration goes to a charity organization. It's a lens for all of us, for you. There's no profit in it, and it's a rescue lens. And you have to order it, try it out, and if many people order it, then Morsha maybe at some point has a momentum that he comes and says, okay, we're going to produce it. So we have to create demand. And if you're interested in the lens, you order it and you communicate with me. You have my email address. I will give you tips and tricks. It's very simple. It's very straightforward. It's very nice surgery.
Thank you. Thank you so much. So welcome Dr. Hina to moderate the next part. Over to Dr. Hina.
Thank you, ma'am. Next, I'd like to introduce Dr. Samuel Masket, who's a retired clinical professor of ophthalmology from the Giffen School of Medicine, UCLA, and is a founding partner of the Advanced Vision Care in Los Angeles. He has also been served as a board of trustee of the American Academy of Ophthalmology. We'll be talking about negative dysphotopsia. Welcome you, sir.
Well, thank you, and good evening, colleagues. It's a pleasure to be here. I'm trying to share my screen, but not getting, there's somebody else's presentation.
I think we need to just welcome Dr. Samuel. We need to just get yours up.
Let me see. I am screen sharing. Okay, so we should have it now.
Perfect.
So, can we see this?
Yes, we can. Yes, and we can hear you as well.
Right. So many of us have experienced patients who are very unhappy with negative dysphotopsia, and it's really been hard to understand why. Most important thing to recognize is that the patient is not crazy. These are my disclosures, and in fact, the last two are relevant in this presentation. So why do some patients complain bitterly, and how can we quantify it? Well, the most common Humphrey visual field that we use only goes out to 30 degrees, and it's not going to find a more peripheral defect, which is typical in the patients complaining with negative dysphotopsia. We don't have a device, so to speak, a dysphotometer that we can use to measure this defect. But Goldman visual fields that go out further should surely be more helpful. And in fact, Malhat Kaina, working in Rudy Neutz's group in Maastricht, demonstrated that you indeed could have some change in the visual field as measured by Goldman. The Goldman device is obsolete, but fortunately, the Hogstride Octopus 900 does have a kinetic Goldman module in its armamentarium. And so we applied this tool to do our own studies. And in fact, we measured, you can see here in a patient complaining of ND in the right eye, we can see this infratemporal defect, which matches their clinical complaints. But so, although we could plot this defect, why should this finding cause such significant complaints? Here's where things get a little bit interesting. When we put a patch over the patient's fellow eye to do the visual field studies, many of them told us that they noted that the ND in the fellow eye actually improved with occlusion of the contralateral eye. This didn't make a lot of sense to us. We thought it had something to do with the fact that we use this paper occlusive patch for a variety of advantages in doing visual field testing. We thought maybe it had something to do with that. So we took the pirate patch and put it on top of that paper patch. And in fact, we found that it gave even more improvement of symptoms in the fellow eye. And this was true for about 80% of the patients we tested. And it was a significant improvement, varying between 50 and 95% from mean of 65%. This is the first time anyone had ever experienced this. So we thought we could use occlusion therapy for ND to enhance the neuroadaptation. And we sent patients home with patching, part-time patching of the fellow eye. And in fact, while the patch was on, they noted that the ND was improved. However, two things. Number one, took the patch away, the symptoms came back. And number two, the treatment was worse than the condition. People don't want to go around with their eye covered. However, we all agree, any of us working with ND, agree that the stimulus is temporally incident light striking the nasal retina. So if we could block the temporal light, which we thought we could do with a peripherally opaque contact lens, we might be able to achieve the same effect of occlusion in the fellow eye. So we got some of these peripherally opaque lenses that we designed, put it on the contralateral eye, ipsilateral eye, both eyes. And in fact, we found we got an initial therapeutic response in 8 of our 10 patients. Again, poorly tolerated. These contact lenses are thick. They tend to be a little bit uncomfortable. And if they move off axis, you'll get complete blockage of the vision. So unfortunately, this didn't prove as a therapeutic benefit, but it gave us something we could do for the first time. And that is we could do a binocular visual field in a patient with ND. So here we take a look at the example on the left with both eyes fully open. We do the Goldman visual field, and we know this very, very large infratemporal defect. We then place this peripherally opaque contact lens on the fellow eye, on the patient's right eye, repeat the visual field, and note that the defect is much smaller and much more peripherally located. So this tells us that under binocular viewing, the ND defect is much larger than under monocular viewing, and that's why the patient isn't crazy. We didn't know this before. And here are a few other examples here of the very large defect with both eyes open and a tiny peripheral defect after one eye is covered with the contact lens. Another example here, there's only about a 50-50 difference between both eyes open and one eye covered. So this tells us why the patient isn't crazy. It also brings up a whole concept. Is this ND is a central nervous system condition? Interestingly, we tried this idea of putting a contact lens on the fellow eye patients with strokes, glaucoma, and other forms of visual field defects, obviously made no difference. The other thing is that ND tends to be much more symptomatic than other causes for visual field defects. And taking it one step further, I have never seen, nor has it been reported, and I've asked many, many colleagues whether they've seen ND in a truly monocular patient, and the answer is no. So it seems as though the central nervous system is in fact necessary to observe negative dysphotopsia. Now that's the clinical side. What are the other causes? What do we think causes ND? You know, a very popular concept today from the optical lab is the illumination gap theory, and that is where light passes in front of the lens, light refracted by the lens leaves this gap, which can then strike the peripheral retina and give it a dark area. This is the most accepted theory today. Interestingly enough, about 20 years earlier, Minas Corneo in Australia published the same concept as an explanation for positive dysphotopsia. So there is a real disconnect between what the optical lab will show in ND and what we see in clinical presentation. Examples, the incidence is greater in females, the incidence is greater in left eyes. Why isn't it close to 100% if that illumination gap theory is true? And why does it most often occur only in one eye of the same patient? Interestingly, ND has not been reported with scleral fixated IOLs. So what is the contribution of the anterior capsulotomy, or the capsule itself? And why is the ND scotoma much greater under binocular viewing? All of this brings in the central nervous system. So looking at how we can help these patients clinically, we published this in 2018. We're very proud to have received the OPSM Award for the best scientific paper that year in the JCRS. And we found that the IOL didn't make any difference whatsoever, that the market share matched the incidence of ND in our patients who required secondary procedures. And what we found that worked the best is elevating the optic in front of the anterior capsule, whether by putting it in the sulcus or by doing what we call reverse optic capture. And this we would do in the fellow eye of a symptomatic patient or the same eye in a symptomatic patient. And we were successful in this publication now 7 years ago, 42 out of 43 eyes with that strategy. So we feel that clinically ND, the final common pathway, is any in-the-bag IOL of any design where the nasal anterior capsulotomy overlies the optic. And our strategies to correct or prevent it is to bring the optic anterior. Here's an example of reverse optic capture. We've taken out the lens material, and I'm cleaning the LECs extensively to try and reduce the incidence of fibrosis after optic capture, which is very significant. Here the OVD is removed from behind the optic, a little bit placed anteriorly to allow us to maneuver the optic. We reach into the bag, we elevate the edge on one side, grab it with a microforcep, and then use a spatula to elevate the opposing edge. And now the loops are superiorly and inferiorly placed in the bag, and the nasal and temporal portions of the optic are on top of the capsule. But there are some negative consequences of these strategies. I mentioned the fibrosis in the bag when the optic is not placed within it. Matter of fact, virtually every patient we've done this as a primary procedure needs a capsulotomy by 3 months. And long-term sulcus placement can lead to iris chafe and decentration. So it led me to design a dysphotopic IOL in which we have a groove that accepts the anterior capsulotomy. So the lens is really basically choked or captured by the capsulotomy. But this lens also has haptics for in the bag and sulcus fixation. Morcha has made this as their Model 90S. It is CE marked. The original, you can see the groove here. The original was modified subsequently, and after 200 cases done in limited clinical trials, it has now been released and launched by Morcha at the recent ESCRS meeting. None of the 200 patients with that IOL had ND. There are 2 other CE marked IOLs that are anterior capsulotomy supported. Marie-José Tassignon's bag and the lens, also made by Morcha, and the Femtis Oculentus manufactured IOL that has these flanges that sits the IOL within the anterior capsulotomy. None of these patients have ever experienced ND. There are other advantages that accrue, though, to anterior capsulotomy supported IOLs besides the absence of ND. They won't rotate, stable toric axis, you cannot have capsule contraction. The tilt, therefore, is limited. And if you center the capsulotomy on the visual axis, and it's better to do with an automated capsulotomy device, you will reduce the higher order aberrations from a diffractive optic, as an example, and you'll have a more predictable ELP. So back to the original question, the patient is not crazy, and we now understand under binocular visual fields why patients can be so symptomatic. So thank you for your attention to this subject, and thank you for inviting my participation.
Thank you so much, Dr. Samuel Masket. That was such a invigorating topic and such a nice discussion on negative dysphotopsia, which actually is such a problem when we have a patient, most of them complaining, and then yet we have nothing much that we can do about it. So perhaps we have to just rethink our location or position of the IOL as compared to, and different types of IOLs, which in the future probably we might be able to use. So thank you so much for this presentation. Thank you.
You're more than welcome.
Thank you. So our next speaker is Dr. Anki Messerschmidt, and the topic today is going to be the laser vision correction with SMILE for myopia and hypermetropia. So over to you.
Yeah. Yes, thank you very much. I try to share my screen. Warte mal, Freigabe stoppen. Bildschirmfreigabe erlauben. Bildschirm teilen. This one. Are you able to see this?
Yes, yes.
Yes, okay. So welcome to laser vision correction with SMILE, or our results with myopia and hyperopia. And my name is Anke Messerschmidt-Roth, and I'm working at the Philipps University in Marburg. Excuse me. So if we talk about SMILE, we have to talk about historical remarks too. The idea of SMILE was born in 2005, and the approval for the market was in 2011, so 6 years later. And now the journey started. Today we have the VisuMax 800 and SMILE Pro. That means 9 seconds for myopia and 12 seconds for hyperopia. Additionally, we have assistance for centration and cyclotorsions. When we talk about our results in Marburg, I have a cohort with me for myopia treated with a VisuMax 800. 12 months postoperatively, we could examine 36 patients, and it could be shown that the stability is very good. It's excellent. From 3 months up to 12 months, we have only a slightly improvement. Why? I don't know. Maybe it's healing. The treated sphere was minus 4.08 in the middle, so a middle range of myopia. It can be shown that the UDVA is 20/25 or better in 99% of our patients. One line lost 6.9%. Predictability is excellent, and the accuracy is very high. We have 95% in the range between plus minus 0.5. I would say for the future, it will become a little bit better if we adapt the nomograms, because with this patients cohort, we used the nomograms from the VisuMax 500 for the 800. If we ask our patients how happy they are, it could be shown that 93% are very satisfied and would choose SMILE again, and 97% would recommend it to friends and families. Only one was very dissatisfied and would not recommend SMILE again. So in conclusion, for myopia, we can say visual and refractive outcomes are very excellent. The stability is perfect and patient satisfaction is very high. Let's come to hyperopia. Hyperopia was allowed or is approved by the FDA in 2024. So we started on the market with this, but I was able to had a follow-up of the patients who are treated 5 years ago. It was the last study for hyperopia SMILE. And it could be shown that the efficacy is very high. We have 88% in the UDVA with 20/25. After 1 year, it was 80%. One reason is maybe, I would say maybe the dry eye, because after 1 year, hyperopic patients has very dry eye. And after 5 years, it's better. So for hyperopia, I mean, the study is still in progress, but we can see visual and refractive outcomes is very good too. And the stability after 5 years is excellent too. But we have to know that there are some limits and we need to know the critical issues. If we have two cases with me, it's an ideal case. This is a male who we treated 6 months ago. He is 28 and the right was 12.1 and the scotopic pupil 7 millimeter. The pre-op prescription was plus 3.5 with a very high astigmatism. After 6 months, it's plano and the visual acuity is excellent. This patient is very happy. But if we have a look at the next case, it's a lady, 24 years old. White is still very high, it's 12.8, and the scotopic pupil is 5.3 millimeter. The pre-op prescription was plus 4.25 with a small astigmatism. After 6 months, the prescription was plus 1.25. And the visual acuity is the same than it was before the operation. So the patient is not unhappy because of the UCVA. It's the same. The patient is unhappy because of the steepening of the keratometry and the dry eye too. So if we talk about hyperopic, we have to talk about critical issues. We need to know the treatment range and the fogging refraction. And our opinion is do not do high errors. Best results are obtained up to 3 dioptrine. The larger the correction, the more important is the optical zone. And dry eye is really an issue, particularly in patients over 40 and if they are female. And you have to have a look at the epithelium and the epithelium mapping. At the moment, we would say thinner caps give better results. And you have to consider possible enhancement options if you plan the treatment. So in fact, SMILE, we have over 12 million procedures worldwide. Lenticle implantation techniques are coming. We have over 1,000 citations in English and the first textbook on SMILE appeared in Chinese. We have also calyx now, kerato-lenticle extraction, because other manufacturers produce or develop their own lenticle extraction procedures. And so the market is growing. And what is the reason for the success for this treatment? It's the biomechanics. In myopia, nobody examined or had studied with hyperopia yet. We have really less dry eye syndrome and the centration as well. So from my point of view, if you consider all these things, have a great and safety start into the world of hyperopic and myopic calyx. Thank you very much.
Thank you so much, ma'am. Next, I'd like to introduce Dr. Mariam Medor, who would be helping us understand about Press Beyond.
Yes, hello. Thank you so much for the invitation. I am sharing my. All right. Do you see the? Oh wait. Do you see my screen?
Yes, ma'am.
Okay, good. So yes, like you just said, I'm going to talk about the Press Beyond LASIK. As we have really high demand of presbyopia treatment, like we have to keep in mind the patients, they want good vision and distance, intermediate and obviously in the near. They want to preserve their optical quality and they also want to get rid of their glasses. They don't want to have any adaptation time. And best of all options, they want to have it reversed in case they don't like it. And obviously they want to have the preservation of the binocular vision. So as we know, there are lenses, multifocal lenses, for example, or EDOF lenses for sure. We don't have all these points, these boxes checked. So what can we do? We can do the presbyond LASIK. There are other LASIK options. Obviously, we know monovision. However, with monovision, we have to be aware that the patients won't get rid of their glasses. They will either need them for intermediate or for near vision. So we can also do multifocal corneas. But what do we have with multifocal corneas? We have the central myopic island. So let's just imagine you drive during the night and the headlights are coming up front.
I think you're having some issues with the internet. Rahul, can you help? Can we have somebody from the IT team, please, helping?
Dr. Mariam is back.
Okay.
Ma'am, you're not audible.
You're mute. Just unmute yourself.
Ma'am, I think their internet connection is not stable because of that.
Just unmute yourself, Mariam. Unmute. You're muted. We have no sound.
Yes, I do
Perfect.
that now.
Perfect. Perfect.
Okay, I said welcome to Germany. We don't have internet right now. So anyways, well, we got stuck here. So you have to put in a 1.3 diopter of defocus, because beyond that point, as you can see in this study here, beyond that point, you get an inhibition of the binocular function. So you don't have binocular function anymore. That's the limit, 1.3. However, with 1.3 diopters, you cannot get rid of the glasses. So why is it modified? Why is it called modified monovision? Because we also add spherical aberrations. We all know that they elongate the focus. We know that from the EDOF lenses, but the first who discovered it was the presbyond, that the spherical aberrations help us to see with an elongated focus. So what we know, however, is that there's also a toxic point and a therapeutic point. So we are not allowed to add more than 0.6. It's not important if it's positive or negative, but we cannot add more than 0.6 microns of spherical aberrations. Beyond that point, you have a toxic effect like contrast sensitivity, for example. So the maximum is 0.6. What we know so far is, first you see the picture here on the, you add 1.3, 1.5 diopters of defocus. Then you add the spherical aberrations. The picture gets less blurred. Also, with the meiosis, you get spherical aberrations. The picture is even clearer. And the neural processing does the rest, as we know, we see with the brain, so it gets to a really clear picture. That's the principle of presbyond. So which has, it's fully corrected for the distance, but due to the spherical aberration, you get an elongated point of focus, which helps us to see in the intermediate, in the blend zone, in the intermediate vision. And the non-dominant eye, you put it to, let's say, 1.3, 1 or 1 diopter, whatever the patient tolerates. And due to the spherical aberration, this also contributes to the intermediate vision. Hence, you see in the distance, in the intermediate, and in the near without glasses. We all know that depending on what you correct, let's say myopia, you naturally, due to the ablation process, you induce spherical aberrations. Myopia positive ones for hyperopia, negative spherical aberrations. But the, let's say, trick of the software is that whatever level you're correcting, the software keeps the spherical aberration beyond the toxic threshold. So they will adjust the spherical aberration to the defocus you are correcting. What do you need to do a presbyopic treatment? First, obviously, the aberrometry. You need to measure the spherical aberration in a 6mm pupil diameter. You need to know, obviously, what is the dominant eye, so dominant testing. You have to do the manifest refraction due to a strict protocol. Push plus as much as you can. Do the binocular balance. This is just a published visual test you have to follow. You confirm that you push plus enough by completing the cyclopedic refraction. You see anisometropia the patient really tolerates, because this also depends on how much does the patient still how much is the accommodation still with the patient. So these are the tests you have to do. This is just to show you the binocular balance protocol and the acceptance test. It looks really a lot. It's not. You can do it. Once you're used to it, you can do it in 10 minutes with a patient. So what does an ideal presbyopic patient look like? First of all, you can do it in young patients as well. They don't have to be presbyopic yet. Just if you plan LASIK, just do a presbyopic profile. Just put only the spherical aberrations in the cornea. Don't do any anisometropia because they have good accommodation. But you can keep the patient longer away from the near glasses, already have the spherical aberrations in the cornea. 3% of the patients are not suitable for presbyopic. They can simply not adapt to anisometropia, to the spherical aberrations in the cornea. So this is what you find out during the acceptance test and the protocol that I just showed you. Also, obviously, you don't do a LASIK with suspicious corneas or severe dry eye. You just treat them beforehand. Well, we said from the multifocal corneas, there is an adaptation process. It's the same with presbyopic. First, you have this normal healing of LASIK. We know that there's swelling, there's a little fluctuation of the vision. But the adaptation of presbyopic is called cross blur. So that's something they have to get used to. 75% take 3 months to get used to. The rest, the 25%, need 6 to 12 months. So what we tell the patient is that they might still need glasses for certain activities in that time. Let's say just your driving glasses in the car, in case you need them while you're still suffering from a little cross blur. But like I said, most of them get adapted really well and really quickly. We see results here published by Reinstein. They've treated the myopia up to -8.5. They've achieved 20/20 and J2 in 95%. Hyperopia, that's something we can't really do in Germany as it's not allowed, is treated up to +5.5. They are up to 77% achieve this. And ametropic patients in 95% as well. The enhancement rates, they vary a little, but as you can see here in the early ages of the microkeratome, the enhancement rates were a little higher than what we see today. Ganesh even published 0% of enhancement rate, Reinstein up to 9%. But that's around the numbers we're having right now. So what do you do if you want to integrate presbyopic in your standard of care? First of all, you make sure that everyone knows change is hard but necessary, because what other options are there right now? You either take out the lens, like you cut the tree, or you just trim the branch a little bit to preserve what's actually working in nature, because usually the lens is still capable of accommodation. So don't just rip it out. Also monovision. I mean, you don't want to have your patient in the 3D movie really bored because they lost binocular vision. You want to see them use Presbyond instead of monovision. Yeah, well, where does Presbyond fit at the beginning? Because obviously at the beginning I have good results. So what we did here at the clinic, we had a strict protocol. We only used really young presbyopes. That means like only up to the age of 50, 52 at most. They were myopic patients or slight hyperopic, because we all know about the regression. We didn't want to start with hyperopic patients so early. So also perfect patients are the ones who are in fear of contrast loss or these altered color perceptions that we know from the multifocal lens. And of course, patients where the vitreous is still attached. We don't want to risk any additional detachment rate. So where does Presbyond fit? But you need to inform the patient. The ametropic patients, we treat them, but they have to be made aware that they might lose a little in the distance, because obviously you're penalizing one eye, the non-dominant eye, a little. So they're really spoiled for the distance and will feel that they have lost something at the beginning. You just inform them. Also in Germany, you are not allowed to drive a car if you have an anisometropia or minus 1.5 in one eye and can be corrected fully to 20/20 vision. So we need to inform them. If you put in the whole minus 1.5, you need to inform them they still need glasses while driving, but you can still use it. Well, like I said, we did not use Presbyond on the hyperopic patient. Obviously, if the refraction falls outside the intended use, they have cataract, suspicious cornea, well, all the things where you wouldn't treat refractively anyway. And so I just brought really 3 quick examples. Here you have a myopic male. He's 49 years old. The vitreous is not attached anymore, but he has diabetes and he sees some snowflake cataract in the slit lamp, but he still achieves full vision. So the cataract is not yet that much, but still in that case, I would take out the lens, because you can foresee that the cataract will proceed and the vitreous is not attached anymore. In this case, you have a 40-year-old, almost ametropic male, but he has an attached vitreous. So, well, you could recommend Presbyond. However, what happens here is that he has very little accommodation left, and therefore he needs a lot of anisometropia to read. So plus 1.25 diopters. But the thing is, he does not tolerate it for the distance. He gets cross blur. So he needs too much addition for reading and cannot tolerate it in the distance. So in this patient, I would tell him, please just wait a little bit longer and until your vitreous is not attached, and then we can take out the lens. And the last patient is a 45-year-old accountant. She is myopic. She has to take off her glasses for reading and is annoyed by this on-off glasses because she needs them for a computer. She can read with her glasses. She tolerates 1 diopter. Her dominant eye is the right one. So we recommended Presbyond because we see here the vitreous is still attached, cornea looks good. So what we did here, this is how the planning system looks like. We took minus 0.75, this is due to our nomogram, on the non-dominant eye, minus 0.75. And this is really what happens. From day 1, she was really happy with distance and near. We only tested that in day 1 and week 1. And 3 months post-op, this was already her last visit with us. She was really happy. She achieved what we've planned, and she did not need any glasses for her life anymore. And just to make sure, because there are some voices who tell us, well, Presbyond is also a multifocal cornea. That's her post-operative pentacam, and it's not multifocal. It's Presbyond. Well, thank you very much. Yeah, this is my talk. Any questions?
Thank you so much, Dr. Miriam. It was a wonderful talk, and so much that we didn't, know that we could do these variations for the Press Beyond. Thank you so much, and especially to plan it out beforehand for patients who are close to 50 or less. I think that was really wonderful. Thank you very much. Thank you.
Thank you.
So may I invite now Dr. Sibel, our dear friend, who's just landed from the airport, and she's going to be presenting her talk on the IOL-CON, updated enhanced support for a calculating toric and non-toric IOL. We've been using a lot of your platform, and welcome. So would you like us to play the recording?
Yes, ma'am.
Okay. Thank you.
Is the screen visible?
Not yet. Now it is.
Okay, ma'am. Starting.
Hello, India. Dear Team Arunodaya, thank you so much for your kind invitation. I'm more than happy and proud to be with you also this year. Dear colleagues and friends, I'm very happy to report about the latest news, the latest upgrades, which have been implemented into IOL-CON, which is the most modern database for IOL specifications and for IOL constants. A little bit of background. ULIP was the first database of its time and set a milestone for optimized IOL constants. From today's perspective, it no longer meets modern requirements. To catch up with those modern standards, Professor Langenbucher developed Professor Heige's ideas further. And in 2017, Langenbucher established and launched the utmost modern database, which is IOL-CON. By now, IOL-CON has established itself as a reliable, worldwide available source for optimized and also individually optimized IOL constants and IOL specifications. So, what is new? A very useful feature has been added to IOL-CON lately, and I would like to introduce you to it. When you look at the printout of some biometers lately, you might see a QR code on top of that page. What's behind those QR codes? Additionally to the clear data on the printout, biometer manufacturers are going to also implement such QR codes on the printout of their biometers. This QR code contains all the data necessary to calculate the corresponding IOL. The QR code can easily be scanned with a simple handheld reader or with a smartphone. These QR codes store the essential biometric data needed for IOL power calculation and will ensure a seamless data transfer for IOL power calculation. The QR codes do not only include all the relevant data for these IOL power calculations, but will also simplify the documentation of the corresponding IOL. The benefits of such a QR code integration is quite clear. They enable an automated data transfer to IOL-CON's lens power calculator. By this, an immediate IOL power calculation is realized by using the lens power calculator. An improved documentation and workflow efficiency is realized by these QR codes as well. This very new feature of IOL-CON is already supported by leading biometer manufacturers like Tomy, Zeiss, and Zima. So, how is this working? When IOL-CON's lens power calculator website is active, the data from the uploaded QR code is automatically transferred to the lens power calculator and can be used there immediately to calculate the corresponding IOL. Such a calculation only takes a second. Following, the user just has to select the respective IOL model only. In addition, the QR code can be used for documentation purpose in the patient's medical file as well. For quite some time, IOL-CON offers already the lens power calculator, which is based on the modern Castro formula. This tool, supporting the surgeon in choosing the correct IOL, is also available free of charge for ophthalmic surgeons directly via IOL-CON's website. It improves the accuracy in IOL power prediction, especially for calculations for eyes which are outside the norm. The prerequisite is the use of current techniques that precisely measure all distances of the eye, like the axial length, the anterior chamber depth, the lens thickness. These are mandatory, and the central corneal thickness, which would be optionally. With this data, in combination with modern formulae, like the Castro formula, IOLs for difficult eyes, those eyes which are outside the norm, can be calculated more reliable compared to using classic formulae. By using IOLCon, the lens power calculator, and the latest implementation of QR codes, you will benefit of an increased accuracy. The lens power calculator with the Castro formula supports superior calculation. It ensures superior IOL power prediction, especially for complex eyes. You will also benefit from an improved efficiency. Scanning the QR code eliminates manual entry errors. So the QR code integration enhances efficiency and reduces human errors. As well, your documentation is streamlined. Such QR codes facilitate accurate patient record keeping. IOLCon is growing steadily. As of today, there is the following, to me, really impressive data included in IOLCon. There are 709 IOLs from 39 manufacturers with more than 34,000 clinical results for 169 lenses included in this database. IOLCon is the only globally available up-to-date web-based database which is free of charge for ophthalmic surgeons. It provides ophthalmic surgeons a documentation of all IOL characteristics which are updated constantly by the manufacturer. Biometer manufacturers integrated a direct download function to IOLCon into their devices. For example, the Anterion, the OR2000, the IOL Master 700, the Revo, the iStar 900, and the Galileo G5. So, what are IOLCon's benefits for the surgeons? It offers you optimized global constants as well as personal optimized constants. It offers you the lens power calculator based on the modern Castro formula. And finally, IOLCon offers you a QR code and biometer printouts, which allows for direct import of data into the lens power calculator, facilitating IOL calculation, order and documentation process. As well, it streamlines your workflow and documentation. By its most up-to-date setup, IOLCon support, provided for free for ophthalmic surgeons, is an indispensable tool and will also meet future demands of an ongoing developing ophthalmic surgery. It is a highly valuable tool for cataract and refractive surgeons worldwide. If you'd like to know more about IOLCon, here are our recommendations. Or if you'd like to follow our latest updates on IOLCon's LinkedIn account. Thank you very much, and all my best wishes for all of you. Bye-bye.
Thank you so much. Can you just unmute Dr. Sibel, please? Tanuj, Dr. Sibel needs to be unmuted. She's having difficulty.
Okay, now
Is
it's
it better? Okay, good.
Yeah, here. Hello, and
Hello.
I'm glad that I could join you on this short notice on this crazy times. I'm so happy to be with you, and thank you all very, very much for inviting me again and for allowing me to present about IOLCon. Thanks a lot. Are there any questions? Can I do anything? Can I answer anything?
I think you did a good job by explaining each and everything. And I think it's such a good tool now. It's such a good way to calculate, and you get better and better, much better because of the number of data that we keep collecting, especially the number of different lenses and IOLs that you have in your gamut now. They're all increasing. Wonderful.
It's steadily growing month by month. We are having new data, new IOL types, new manufacturers, and it's amazing. And it's, to me personally, it's such a great tool because it's free for all the surgeons, and it's the biggest tool available with the biggest data inside. So to me, anything which comes out of IOLCon is reliable because it's such a huge database, huge amount of information is stored in the database. So the results, to me, will be excellent.
Good.
Thank you so
Excellent.
Thank you.
Thank you so much. And I'm happy that you're back home now. So good for you.
I'm not back home. I'm traveling. I landed I'm in Romania today, and everything was delayed. And I'm so glad that I just made it in time for my lecture and to see you and to meet you and to be with you. Thank you so much.
Thank you. It's an honor for us. Thank you. Bye-bye.
Bye-bye, dear. Bye-bye.
Thank
See
you.
you soon. Bye-bye.
Thank you, Dr. Hina.
Bye.
Thank you for the opportunity.
Thank you. Bye. That's been a lovely session, and I think we really had a good time. Very educative and very inspiring. All the talks are wonderful. Bye.
Bye.